Welcome to NCLEX-ReviewPro, your complete self-study toolkit for focused, high-yield NCLEX preparation. In this Q&A session, we're tackling Fundamentals of Nursing, one of the most important and reasoning-heavy areas of your exam. Fundamentals is not just about memorizing definitions. It is about learning how nurses think, assess, prioritize, communicate, delegate, and keep clients safe. Here, every question has a purpose. This session includes 42 high-yield questions divided into 5 focused sections. Section 1 covers nursing process and clinical judgment. Section 2 covers safety and infection control. Section 3 covers management of care, delegation, and prioritization. Section 4 covers basic assessment and foundational care. And Section 5 covers nutrition, hydration, and elimination basics. Throughout this session, we'll work through the major NCLEX-style question formats, including multiple choice, select all that apply, matrix grids, drop-down close items, ordered response, highlight the text, and bow tie-style clinical judgment questions. Each question is designed to challenge how you recognize cues, analyze information, prioritize care, and choose the safest nursing action. We'll break down each question one by one, explaining the reasoning behind the correct answer and the exam traps behind the wrong answers. The goal is not just to help you memorize facts. The goal is to help you think like a nurse. Use timestamps to navigate to different sections. Pause when you need to. Take notes of important points. This is NCLEX-ReviewPro. Let's begin. Section 1. Nursing process, healthcare delivery, and clinical judgment. In this section, we are building the foundation for how nurses think through care. We'll focus on ADPIE, assessment, analysis, planning, implementation, evaluation, recognizing cues, prioritizing concerns, taking action, reassessment, pain assessment, teach-back, and outcome writing. We'll also connect these ideas to healthcare delivery, advocacy, teamwork, referrals, and helping clients navigate the healthcare system. These topics are high yield for the NCLEX because many questions are not simply asking what you know. They are asking what the nurse should notice, what the finding means, what action comes first, and how to keep the client safe. Question 1. Matrix grid question. All right, let's break this down. The nurse is caring for an older adult client admitted to a medical surgical unit after a fall at home. The client is alert and oriented, but reports feeling weak when standing. The nurse notes that the client's gait is unsteady. The call light is on the bedside table, but it is out of reach. And the client says, "I do not want to bother anyone when I need the bathroom." The nurse uses the nursing process to provide safe care. And the question is asking you to identify which step of the nursing process is being demonstrated by each nursing action. This is a matrix grid question. That means each row gives you a nursing action, and you have to match that action with the correct step of the nursing process. Your choices are assessment, diagnosis or analysis, planning, implementation, and evaluation. Now let's look at the actions. Number 1. The nurse observes the client's gait and asks about dizziness when standing. Number 2. The nurse identifies that the client is at increased risk for falls related to weakness and unsafe toileting behavior. Number 3. The nurse sets a goal that the client will use the call light before getting out of bed during the shift. Number 4. The nurse places the call light within reach, applies non-skid socks, and keeps the bed in the lowest position. Number 5. The nurse checks later in the shift whether the client used the call light before attempting to stand. Number 6. The nurse reviews the assessment findings and determines that toileting assistance should be offered every 2 hours. Take a moment and think about your answer. The correct answers are: number 1 is assessment. Number 2 is diagnosis or analysis. Number 3 is planning. Number 4 is implementation. Number 5 is evaluation. And number 6 is diagnosis or analysis. Now let's walk through the clinical reasoning. The nursing process is not just a list to memorize, it is a clinical judgment framework. First, the nurse collects information. Then the nurse analyzes what that information means. Then the nurse creates a plan. Then the nurse takes action. And finally, the nurse evaluates whether the care worked. In this scenario, the main concern is safety, specifically fall risk. The client has weakness, unsteady gait, the call light is out of reach, and the client does not want to ask for help with toileting. Those are the cues. The nurse must recognize those cues, analyze the fall risk, plan an outcome, implement safety measures, and then evaluate whether the client is actually using the call light before standing. Now let's go row by row. Number 1 says the nurse observes the client's gait and asks about dizziness when standing. This is assessment. The nurse is collecting data. Observing gait is objective data. Asking about dizziness is subjective data. At this point, the nurse is not taking action yet. The nurse is recognizing cues. Number 2 says the nurse identifies that the client is at increased risk for falls related to weakness and unsafe toileting behavior. This is diagnosis or analysis. The nurse is interpreting the data. The nurse is taking the cues and deciding what they mean. Weakness, unsteady gait, and reluctance to call for help all point toward increased fall risk. Number 3 says the nurse sets a goal that the client will use the call light before getting out of bed during the shift. This is planning. Planning means the nurse is setting a measurable outcome or choosing interventions. Notice that this goal includes a client behavior, using the call light, and a time frame, during the shift. That is what makes it stronger than a vague goal like, the client will stay safe. Number 4 says, the nurse places the call light within reach, applies non-skid socks, and keeps the bed in the lowest position. This is implementation. The nurse is now taking action. These are direct fall prevention interventions. Number 5 says, the nurse checks later in the shift whether the client used the call light before attempting to stand. This is evaluation. Evaluation means the nurse checks whether the goal was met. The question here is, did the intervention work? Did the client use the call light? Did the safety plan reduce the risk? Number 6 says, the nurse reviews the assessment findings and determines that toileting assistance should be offered every 2 hours. This is diagnosis or analysis. This one can be tricky. The nurse is not yet offering toileting assistance in this sentence. The nurse is reviewing the cues and deciding what the client needs. That thinking process is analysis. If the sentence said, the nurse offers toileting assistance every 2 hours, then that would be implementation. But here, the nurse is interpreting the findings and identifying a care need. NCLEX alert. On the NCLEX, do not match ADPIE by memorizing words only. Ask yourself what the nurse is doing. Collecting cues is assessment. Interpreting cues is analysis. Setting goals is planning. Taking action is implementation. Checking if the action worked is evaluation. The key takeaway is this. ADPIE is the structure behind clinical judgment. In a safety question, the nurse must first notice the cues, then determine what they mean, then plan and perform interventions, and finally reassess whether the client is safer. For fall risk questions, always connect the assessment findings to prevention, because the goal is not just to identify risk, but to stop harm before it happens. Now let's move on to the next question. Question 2. NGN Matrix Grid. Recognizing versus analyzing cues. Clinical scenario. The nurse responds to the bed alarm of an older adult client admitted with a severe urinary tract infection. The nurse enters the room and finds the client lying on the floor near the foot of the bed. The client's gown and linens are soiled with urine. The nurse assesses the client, obtains vital signs, notifies the healthcare provider, and prepares to document the event in the electronic medical record. And the question is asking, for each possible documentation entry, identify whether it is appropriate to include in the client's medical record or whether it requires revision and should not be documented as written. This is a matrix grid question. You will look at each possible documentation entry and decide if it is appropriate to document or if it requires revision. Option A. Blood pressure, 102/60 millimeters of mercury, pulse, 97 per minute, and SpO2, 98% on room air. Option B. Client found at 23:10, soiled with urine, lying on the floor near the foot of the bed. Option C. Client has continuously refused to use the call bell as instructed. Option D. Client states, "My bottom hurts and I feel a little bit dizzy." Option E. Jones, MD, notified at 23:22, will continue to monitor for indications of injury. Take a moment and think about your answer. The correct answers are: Option A is appropriate to document, Option B is appropriate to document, Option C requires revision and should not be documented as written, Option D is appropriate to document, and Option E is appropriate to document. The main idea in this question is safe, factual documentation. After a client is found on the floor, the nurse must document what was observed, what was measured, what the client stated, what nursing actions were taken, who was notified, and what monitoring will continue. The nurse should not document assumptions, blame, or vague interpretations. Now let's go through each option. Option A says, blood pressure 102/60, pulse 97, and SpO2 98% on room air. This is appropriate to document. These are objective assessment findings. After a fall, the nurse must document measurable findings such as vital signs, oxygen saturation, pain, level of consciousness, and any signs of injury. This helps establish the client's post-fall baseline. Option B says, client found at 23:10, soiled with urine, lying on the floor near the foot of the bed. This is appropriate to document. This is factual and observable. The nurse is documenting what was directly seen: the time, the location, the client's position, and the client's condition. This is strong documentation because it avoids assumptions about how the client got to the floor. Option C says, client has continuously refused to use the call bell as instructed. This requires revision and should not be documented as written. This statement is judgmental and vague. Words like continuously refused can sound blaming unless they are supported by exact facts. A better documentation entry would be, client was reminded at 2100 and 2200 to use call light for toileting assistance. Documentation should be objective, specific, and non-judgmental. Option D says, client states, my bottom hurts and I feel a little bit dizzy. This is appropriate to document. This is subjective client data, and it should be documented in quotation marks when possible. The client's report of pain and dizziness is important because it may indicate injury, orthostatic symptoms, weakness, or ongoing fall risk. Option E says, Jones, MD, notified at 23:22, will continue to monitor for indications of injury. This is appropriate. This documents follow-up and communication. After a fall, the nurse should document who was notified, when the notification occurred, relevant provider instructions, and the plan for ongoing monitoring. Now here is the NCLEX alert. On NCLEX, this concept may be tested as a documentation question, a fall risk question, a legal and ethical question, or an NGN cue recognition question. Watch for these traps. Do not document assumptions such as client fell out of bed unless you witnessed it. Do not blame the client with wording such as refused, non-compliant, or would not listen, unless the charting includes exact facts. Do not document opinions such as client was careless or client seemed confused without supporting observations. NCLEX wants the nurse to document facts, not interpretations. The key takeaway is this: accurate documentation is objective, specific, and neutral. In a post-fall situation, the nurse documents what was seen, measured, heard, and done. Good documentation protects the client, supports continuity of care, and shows the nurse's clinical judgment.
Question 3. NGN type. Bow tie. Clinical scenario. The nurse is caring for a post-operative client receiving demand dose hydromorphone through a patient-controlled analgesia pump, also called a PCA pump. When the nurse enters the room, the client appears very drowsy. The nurse obtains the following assessment data: temperature 97.2 degrees Fahrenheit or 36.2 degrees Celsius orally, pulse 52 beats per minute, blood pressure 101/58 millimeters of mercury, respiratory rate 11 breaths per minute, SpO2 93% on 3 liters of oxygen by nasal cannula. The client responds slowly when the nurse calls the client's name. And the question is asking you to complete the bow tie by selecting 3 things. First, 1 most likely complication. Second, 2 priority nursing actions. And third, 2 assessment findings the nurse should continue to monitor. For the most likely complication, the options are: Option A, opioid-related oversedation with respiratory depression. Option B, post-operative wound infection. Option C, hypovolemic shock. Option D, pulmonary embolism. For priority nursing actions, the options are: Option E, attempt to arouse the client and reassess respiratory status. Option F, document the findings in the medical record. Option G, check the PCA pump medication administration history. Option H, contact the primary healthcare provider immediately before further assessment. Option I, encourage the client to press the PCA button for better pain control. For assessment findings to continue monitoring, the options are: Option J, respiratory rate and depth. Option K, level of sedation and ability to stay awake. Option L, bowel sounds. Option M, surgical dressing drainage. Option N, appetite and food preferences. Take a moment and think about your answer. All right, let's break this down. The correct answers are: for the most likely complication, Option A, opioid-related oversedation with respiratory depression. For priority nursing actions, Option E, attempt to arouse the client and reassess respiratory status. And Option G, check the PCA pump medication administration history. For assessment findings to continue monitoring, Option J, respiratory rate and depth. And Option K, level of sedation and ability to stay awake. Now let's walk through the reasoning for every option. For the most likely complication, Option A, opioid-related oversedation with respiratory depression. This is correct. Hydromorphone can depress the central nervous system and slow respirations. The drowsiness, slow response, respiratory rate of 11, low pulse, mild hypotension, and oxygen saturation of 93% on oxygen all support this complication. Option B, post-operative wound infection. This is incorrect. A wound infection would be suggested by fever, increased wound drainage, redness, warmth, swelling, or an elevated white blood cell count. This client's strongest cues are sedation and decreased respiratory rate, not infection. Option C, hypovolemic shock. This is incorrect. Hypovolemic shock is usually associated with tachycardia, hypotension, cool clammy skin, weak pulses, and decreased urine output. This client has bradycardia and excessive drowsiness, which fit opioid oversedation more strongly than shock. Option D, pulmonary embolism. This is incorrect. A pulmonary embolism may cause sudden dyspnea, chest pain, tachycardia, tachypnea, anxiety, and decreased oxygen saturation. Here, the main issue is decreased alertness with slow respirations, which points toward opioid-related respiratory depression. Now let's look at the priority nursing actions. Option E, attempt to arouse the client and reassess respiratory status. This is correct. This is the first priority action. The nurse must assess the client before focusing on the equipment, documentation, or provider notification. A sleeping client may have a lower respiratory rate and oxygen saturation that improve when aroused. But if the client is difficult to arouse or the respiratory depression continues, the nurse must take further action. Option F, document the findings in the medical record. This is incorrect as a priority action. Documentation is important, but it is not the first action when the client may be experiencing respiratory depression. The nurse must first assess the client and address safety. Option G, check the PCA pump medication administration history. This is correct. After assessing and attempting to arouse the client, the nurse should check the PCA history to determine how much opioid the client has received. This helps identify whether excessive opioid dosing may be contributing to oversedation. Option H, contact the primary healthcare provider immediately before further assessment. This is incorrect. The provider may need to be notified if the client remains difficult to arouse or if respiratory depression continues, but the nurse should first assess the client directly. On NCLEX, assessing the client usually comes before calling the provider, unless immediate emergency activation is required. Option 1. Encourage the client to press the PCA button for better pain control. This is incorrect and unsafe. The client is already very drowsy and breathing slowly. More opioid could worsen sedation and respiratory depression. Now let's look at the assessment findings to continue monitoring. Option J, respiratory rate and depth. This is correct. Respiratory depression is the major danger of opioid therapy. The nurse must monitor not only how many breaths the client takes per minute, but also the depth and quality of those respirations. Option K, level of sedation and ability to stay awake. This is correct. Sedation often occurs before severe respiratory depression. A client who is difficult to arouse, cannot stay awake, or becomes increasingly somnolent needs immediate reassessment and possible opioid-related intervention. Option L, bowel sounds. This is incorrect for this priority situation. Opioids can cause constipation, so bowel function matters in routine care. But in this scenario, airway, breathing, sedation level, and oxygenation come first. Option M, surgical dressing drainage. This is incorrect. Post-operative wound assessment is important, but it does not address the immediate risk in this scenario. The urgent concern is respiratory depression from opioid therapy. Option N, appetite and food preferences. This is incorrect. Nutrition is not the priority when the client has abnormal respiratory and sedation findings. The nurse must first focus on breathing and level of consciousness. Now, here's the NCLEX alert. NCLEX may present opioid and PCA safety questions with a client who is difficult to arouse, has a respiratory rate below the expected range, has low oxygen saturation despite oxygen therapy, has bradycardia or hypotension, and is receiving a PCA pump or opioid infusion. The major trap is choosing to check the PCA pump first, call the provider first, or document first. Remember the NCLEX rule. Assess the client before the equipment, assess the client before calling the provider, and stabilize the client before documenting. If a client receiving opioids is drowsy with slow respirations, think sedation, then respiratory depression, then airway and breathing priority. The key takeaway is this: hydromorphone and other opioids can cause sedation, respiratory depression, bradycardia, and hypotension. In a client with a PCA pump, the nurse must assess the client before checking the pump. The first action is to attempt to arouse the client and reassess respiratory status. The PCA medication history is checked after the client is assessed. Respiratory rate, respiratory depth, oxygen saturation, and level of sedation are priority monitoring findings. Documentation and provider notification are important, but they occur after assessment and initial safety actions. Never encourage additional opioid use when the client is excessively sedated or breathing slowly. Okay, let's move on to the next one. Question 4. NGN, highlight the text. Pain assessment and bias. Clinical scenario. A nurse is precepting a newly licensed nurse on a medical surgical unit. The newly licensed nurse is assigned to care for an older adult client with chronic back pain. The client reports pain as 8 out of 10 and states, "I have had this pain for years, but today it is making it hard for me to sleep or walk." The preceptor asks the newly licensed nurse to explain how pain will be assessed and managed. And the question is asking, highlight the statement by the newly licensed nurse that requires further teaching. The new nurse statements are, I will ask the client to rate the pain on a scale of 0 to 10. I will reassess the client after pain medication to determine whether it was effective. I will look for signs that the client may be exaggerating the pain. I know that pain in an older adult may appear as sleep disturbance, depression, or changes in mobility. Take a moment and think about your answer. All right, let's break this down. The correct statement to highlight is, I will look for signs that the client may be exaggerating the pain. This statement requires further teaching because it shows bias. The most important concept here is that pain is subjective. Pain is what the client says it is. The nurse should assess the client's pain, believe the client's report, intervene appropriately, and then reassess the response. Now let's go through each statement. The first statement says, I will ask the client to rate the pain on a scale of 0 to 10. This is a correct statement. A numeric pain scale is appropriate when the client can communicate. It helps the nurse collect baseline data, monitor pain trends, and evaluate whether interventions are working. The second statement says, I will reassess the client after pain medication to determine whether it was effective. This is also a correct statement. After giving pain medication, the nurse must evaluate the client's response. Reassessment helps determine whether the pain improved, whether another intervention is needed, and whether any adverse effects occurred. The third statement says, I will look for signs that the client may be exaggerating the pain. This is the statement that requires further teaching. This wording is judgmental and unsafe. The nurse should not assume that a client is exaggerating pain. Pain may not always match the nurse's expectations, facial expression, vital signs, or diagnosis. Bias can lead to undertreatment, delayed care, and poor client outcomes. The fourth statement says, I know that pain in an older adult may appear as sleep disturbance, depression, or changes in mobility. This is a correct statement. Older adults may show pain through sleep problems, decreased mobility, changes in gait, reduced socialization, depression, irritability, or decreased appetite. The nurse should assess carefully and not assume the client is just aging or not really in pain. Now here is the NCLEX alert. NCLEX may present this concept as a negative event question with wording like, which statement requires further teaching? Which action by the nurse requires intervention? Or, Which statement indicates a misunderstanding of pain management? Be careful with judgmental words like exaggerating, drug-seeking, manipulating, attention-seeking, or not really in pain. The exam wants you to remember that pain is what the client says it is. The key takeaway is this: pain is subjective, and the client's self-report is the best indicator. A numeric pain scale is appropriate when the client can communicate, and the nurse must reassess pain after medication or other interventions. Older adults may show pain through sleep disturbance, depression, decreased mobility, gait changes, or reduced socialization. Nurses should avoid bias and never assume the client is exaggerating pain. Pain management includes both pharmacological and non-pharmacological interventions, and in NCLEX questions, judgmental wording is usually a red flag. Okay, let's move on to the next question. Question 5. NGN type drop-down close. Assessment versus implementation versus evaluation. Clinical scenario. The nurse is caring for a client admitted after a fall at home. The client is alert and oriented, but reports weakness when walking to the bathroom. The nurse notices that the client reaches for the bedside table when standing and appears unsteady. The nurse uses the nursing process to determine safe care. And the question is asking you to complete each sentence by selecting the correct nursing process phase from the drop-down options. The drop-down options are assessment, implementation, and evaluation. Now let's go through each one. Sentence 1 says, the nurse asks the client, "Do you feel dizzy when you stand?" and observes the client's gait. This action is blank. Take a moment to think about. Correct answer is assessment. The nurse is collecting data. Asking about dizziness gives subjective data because it comes from what the client reports. Observing the client's gait gives objective data because it is what the nurse sees. The nurse is recognizing cues related to fall risk, such as dizziness, weakness, unsteady gait, and unsafe mobility. This is not implementation because the nurse is not yet taking action to fix the problem. And this is not evaluation because the nurse is not checking whether an intervention worked. This is the initial cue collection phase. Sentence 2 says, the nurse places the call light within reach, applies non-skid socks, and lowers the bed. This is blank if you think about it. It is implementation. The nurse is taking action to reduce fall risk. These are direct safety interventions. This is not assessment because the nurse is not gathering new data in this sentence. And this is not evaluation because the nurse is not measuring whether the intervention was successful yet. The nurse is doing the intervention, so this is implementation. Sentence 3 says, later in the shift, the nurse checks whether the client used the call light before getting out of bed. This action is blank. RN aspirants, please utilize your reasoning and figure out correct answer. This is actually evaluation. The nurse is checking whether the safety plan worked. Evaluation asks, did the client meet the expected outcome? In this case, the outcome is whether the client used the call light before getting up. This may sound like assessment because the nurse is collecting information, but the purpose is different. The nurse is judging whether an intervention was effective, so this is evaluation. Sentence 4 says, the nurse reassesses the client's pain level 45 minutes after giving prescribed pain medication. This is blank. Take your time. Correct answer is evaluation, again. Reassessment after an intervention is a key part of evaluation. Giving the pain medication would be implementation, but checking whether the pain medication worked is evaluation. That is the important difference. Initial pain rating is assessment. Pain reassessment after medication is evaluation. Sentence 5 says, the nurse teaches the client to call for assistance before walking to the bathroom. Blank. This is implementation. Teaching is a nursing intervention. The nurse is taking action to prevent injury and promote safe behavior. This is not assessment because the nurse is not collecting data. And it is not evaluation because evaluation would happen later when the nurse checks whether the client actually used the call light before getting out of bed. Now, here is the NCLEX alert. On NCLEX, the word reassess after an intervention usually means evaluation. Teaching, applying precautions, and giving care are implementation. Initial cue collection is assessment. And remember, assess the client before equipment, provider calls, or documentation unless immediate rescue is needed. The key takeaway is this. Assessment means collect cues, implementation means take action, and evaluation means check if the action worked. Teaching is implementation. Reassessment after treatment is evaluation. If you can identify what the nurse is doing in the sentence, you can usually identify the correct phase of the nursing process. Okay, let's move on. Question 6. NGN Matrix Grid. Ethics, Advocacy, and Navigating Community Resources. Clinical scenario. The nurse is volunteering with an outreach program at a temporary shelter after a severe environmental disaster. Several individuals experiencing homelessness arrive for basic health screening. Many have lost access to medications, identification, transportation, food, clean water, and safe sleeping areas. The nurse must provide ethical, safe, and realistic care while helping clients connect with available health and social services. And the question is asking, for each nursing action, identify whether the action is appropriate or whether it requires intervention. This is a matrix grid question. You will look at each nursing action and decide whether the nurse is practicing safely, ethically, and within scope, or whether the action needs correction. Here are the nursing actions. Option A. The nurse first screens clients for urgent needs such as difficulty breathing, chest pain, uncontrolled bleeding, altered mental status, dehydration, or exposure-related injury. Option B. The nurse tells a client, "You need to go to the hospital now," but does not explain the reason or ask about the client's concerns. Option C. The nurse contacts the outreach social worker to help a client replace lost identification and connect with shelter, food, transportation, and medication refill resources. Option D. The nurse documents a client as non-compliant and careless because the client has not taken prescribed blood pressure medication since the disaster. Option E. The nurse provides wound cleansing, basic dressing supplies, and teaching about signs of infection within the volunteer clinic's protocol. Option F. The nurse gives a client another person's leftover prescription medication because the client cannot afford a refill. Option G. The nurse asks the client what they are most worried about today and includes the client's stated concern in the plan of care. Option H. The nurse shares a client's housing status and diagnosis with another volunteer who is not involved in the client's care. Take a moment and think about your answer. All right, let's break this down. The correct answers are: Option A is appropriate. Option B requires intervention. Option C is appropriate. Option D requires intervention. Option E is appropriate. Option F requires intervention. Option G is appropriate. And Option H requires intervention. The main idea in this question is that disaster outreach still requires nursing judgment, ethics, advocacy, confidentiality, and safe resource navigation. The nurse should prioritize urgent clinical needs first, avoid bias, stay within scope, protect privacy, and connect clients with the right resources. Now let's go through each option. Option A says the nurse first screens clients for urgent needs such as difficulty breathing, chest pain, uncontrolled bleeding, altered mental status, dehydration, or exposure-related injury. This is appropriate. Even in a temporary shelter or outreach setting, the nurse must still prioritize immediate threats to life and safety. Airway and breathing problems, chest pain, uncontrolled bleeding, altered mental status, dehydration, hypothermia, heat illness, and exposure-related injuries require prompt follow-up. Option B says the nurse tells a client, "You need to go to the hospital now," but does not explain the reason or ask about the client's concerns. This requires intervention. The issue is not that the client may need emergency care. The issue is the way the nurse communicates. The nurse should explain the clinical concern, assess the client's barriers, ask about fears or preferences, and help arrange safe transfer if emergency care is needed. This supports informed decision-making and client autonomy. Option C says the nurse contacts the outreach social worker to help a client replace lost identification and connect with shelter, food, transportation, and medication refill resources. This is appropriate. This is health system navigation. The nurse does not need to personally fix every social need. The nurse should connect the client with the right team members and community resources. Social workers and case managers are important partners for housing, transportation, medication access, insurance or benefit issues, and follow-up care. Option D says the nurse documents the client as non-compliant and careless because the client has not taken prescribed blood pressure medication since the disaster. This requires intervention. That wording is judgmental and unsafe. The client may have been unable to take medication because of displacement, lack of money, transportation barriers, lost prescriptions, pharmacy closure, or other disaster-related barriers. A better note would be factual, such as, client reports no blood pressure medication for 5 days after evacuation. That wording documents the situation without blame. Option E says the nurse provides wound cleansing, basic dressing supplies, and teaching about signs of infection within the volunteer clinic's protocol. This is appropriate. Basic wound care, infection prevention teaching, and referral for worsening symptoms are appropriate when they are within the nurse's scope and the clinic's protocol. The nurse is providing safe care while also staying within role expectations. Option F says the nurse gives a client another person's leftover prescription medication because the client cannot afford a refill. This requires intervention. This is unsafe and outside appropriate nursing practice. Prescription medications should not be shared. The nurse should help the client access a provider, pharmacy, emergency refill process, clinic, or social service resource instead. Option G says the nurse asks the client what they are most worried about today and includes the client's stated concern in the plan of care. This is appropriate. This supports client-centered care. In outreach settings, addressing the client's immediate concern can build trust and improve follow-up. The nurse should combine client priorities with clinical priorities. Option H says the nurse shares a client's housing status and diagnosis with another volunteer who is not involved in the client's care. This requires intervention. This violates privacy and confidentiality. Client information should be shared only with team members who need that information to provide care or coordinate services. Now, here is the NCLEX alert. NCLEX may test this concept under advocacy, ethics, referrals, disaster response, or community care. Do not choose judgmental answers like non-compliant, careless, or refuses care. The nurse should connect clients with resources, not personally fix every social problem. Emergencies come first, but client dignity and informed decision-making still matter. And client information should only be shared on a need-to-know basis. The key takeaway is this: homelessness and displacement are health risk factors, not character flaws. In disaster outreach, the nurse should prioritize urgent clinical risks first. Use social work, case management, public health, shelters, pharmacies, and clinics for resource navigation. Stay within scope and protocol, advocate without bias, and protect confidentiality. Okay, let's keep developing such great clinical reasoning moving into this. Question 7. NGN type bow tie. Smart outcome writing and anticipatory guidance. Clinical scenario. The nurse is providing anticipatory guidance to a client with early Alzheimer's disease and osteoarthritis. The client has mild forgetfulness and early cognitive changes. The client also reports joint stiffness when walking and occasional difficulty getting in and out of the bathtub. The nurse is writing an educational goal to guide teaching. And the question is asking you to complete the bow tie by selecting 3 things. First, 2 client cues that support the priority teaching need. Second, 1 best educational goal. And third, 2 reasons the goal is appropriate. For client cues, the options are: Option A, mild forgetfulness and early cognitive changes. Option B, osteoarthritis with joint stiffness during mobility. Option C, interest in attending a dementia support group. Option D, ability to prepare simple meals independently. For the best educational goal, the options are: Option E, the client will demonstrate proper organization of medications in a weekly pill box by the end of the teaching session. Option F, the client will identify and attend a support group meeting for clients with dementia by the end of the month. Option G, the client will verbalize 2 home safety changes that can prevent falls during disease progression by the end of the session. Option H, the client will verbalize 3 examples of easy, nutritious meals that can be prepared independently by the end of the clinic visit. For reasons the goal is appropriate, the options are: Option 1, the goal is measurable and time-limited. Option J, the goal prepares the client for a future safety risk related to disease progression. Option K, the goal focuses mainly on social support rather than safety. Option L, the goal avoids client involvement and focuses only on caregiver responsibility. Take a moment and think about your answer. All right, let's break this down. The correct client cues are: Option A, mild forgetfulness and early cognitive changes. And Option B, osteoarthritis with joint stiffness during mobility. The best educational goal is Option G. The client will verbalize 2 home safety changes that can prevent falls during disease progression by the end of the session. And the reasons this goal is appropriate are: Option 1, the goal is measurable and time-limited. And Option J, the goal prepares the client for a future safety risk related to disease progression. Now let's walk through the reasoning. The key idea in this question is smart outcome writing combined with anticipatory guidance. A SMART goal should be specific, measurable, realistic, client-centered, and time-limited. Anticipatory guidance means the nurse is not only teaching for today's problem, the nurse is helping the client prepare for likely future risks. In this scenario, the priority risk is falls. Why? Because the client has early cognitive changes from Alzheimer's disease and mobility limitations from osteoarthritis. That combination creates a strong safety concern. Now let's go through the client cues. Option A, mild forgetfulness and early cognitive changes. This is correct. Early Alzheimer's disease can affect memory, judgment, and safety awareness. Even mild cognitive changes increase the need for anticipatory teaching about future risks in the home. Option B, osteoarthritis with joint stiffness during mobility. This is correct. Osteoarthritis can affect balance, gait, transfers, and safe movement. When mobility problems are combined with cognitive changes, the client's fall risk increases. Option C, interest in attending a dementia support group. This is incorrect. A support group can absolutely be helpful, but it does not identify the most immediate safety concern in this question. The question is asking for the cues that support the priority teaching need, and the strongest teaching need here is fall prevention. Option D, ability to prepare simple meals independently. This is incorrect. Meal preparation may be important, but it is not the strongest cue for fall prevention anticipatory guidance. The key safety issue is cognitive decline plus mobility limitation. Now let's look at the best educational goal. Option E, the client will demonstrate proper organization of medications in a weekly pill box by the end of the teaching session. This is incorrect. This goal is measurable and it may be useful, but it focuses on medication management. It does not best address the priority fall risk concern in this scenario. Option F, the client will identify and attend a support group meeting for clients with dementia by the end of the month. This is incorrect. This goal may support coping and community connection, but it is less directly related to immediate safety. It also depends on follow-through beyond the teaching session, and may depend on transportation or caregiver support. Option G, the client will verbalize 2 home safety changes that can prevent falls during disease progression by the end of the session. This is correct. This is the best goal because it is client-centered, measurable, time-limited, and directly related to safety. It prepares the client for future challenges related to Alzheimer's disease progression and osteoarthritis. Option H, the client will verbalize 3 examples of easy, nutritious meals that can be prepared independently by the end of the clinic visit. This is incorrect. This goal is measurable, but it focuses on nutrition and independent meal preparation. It does not address the priority risk created by cognitive changes and impaired mobility. Now let's look at the reasons the goal is appropriate. Option 1. The goal is measurable and time-limited. This is correct. A strong outcome includes a specific behavior and a time frame. Verbalize 2 home safety changes by the end of the session can be evaluated clearly. Option J. The goal prepares the client for a future safety risk related to disease progression. This is correct. Anticipatory guidance prepares the client for expected future needs. Fall prevention is especially important when cognition and mobility are both affected. Option K. The goal focuses mainly on social support rather than safety. This is incorrect. That describes the support group option, not the best goal. Social support is beneficial, but safety is the priority in this scenario. Option L. The goal avoids client involvement and focuses only on caregiver responsibility. This is incorrect. The correct goal includes the client directly. The client verbalizes home safety changes, which supports participation and understanding. Now, here's the NCLEX alert. On NCLEX, best goals are specific, measurable, client-centered, realistic, and time-limited. Anticipatory guidance means preparing for likely future risks, not only today's problem. With cognitive decline plus mobility issues, think fall prevention and home safety. Do not pick a goal only because it sounds nice. Pick the goal tied to the priority risk. The key takeaway is this: SMART goals must be measurable and have a time frame. Alzheimer's disease increases future safety risks, and osteoarthritis increases fall risk because of mobility limits. When fall risk cues are present, safety goals usually outrank social support or nutrition goals. Client teaching goals should also be something the nurse can evaluate, such as whether the client can verbalize 2 home safety changes by the end of the session. Okay, let's move on to the next question. Question 8, multiple choice. Teach back as evaluation of learning. Clinical scenario. The nurse is providing discharge instructions to a client who is newly prescribed an inhaler. The client has limited health literacy and says, "I usually forget medical instructions once I get home." And the question is asking, which teaching method is most effective for the nurse to use to confirm the client understands the instructions? The options are: Option 1. Give the client written instructions about inhaler use. Option 2. Show the client a video explaining how to use the inhaler. Option 3. Ask the client to explain and demonstrate how the inhaler will be used at home. Option 4. Verbally repeat the instructions slowly before discharge. Take a moment and think about your answer. Alright, let's break this down. The correct answer here is option 3. Ask the client to explain and demonstrate how the inhaler will be used at home. This is the best answer because it uses teach back and return demonstration. The nurse is not only giving information, the nurse is evaluating whether the client actually understands the instructions and can perform the skill safely. Now let's go through the reasoning behind each option. Option 1 says, give the client written instructions about inhaler use. This is incorrect. Written instructions can support learning, but they do not confirm that the client understands the teaching or can use the inhaler correctly. Written materials should be clear and simple, especially for a client with limited health literacy, but written instructions alone are not the best way to evaluate learning. Option 2 says, show the client a video explaining how to use the inhaler. This is incorrect. A video can be helpful, especially for a visual learner, but watching a video is still passive learning. It does not prove that the client understands the information or can apply it safely at home. Option 3 says, ask the client to explain and demonstrate how the inhaler will be used at home. This is correct. This is teach back. Teach back asks the client to repeat the information in their own words or demonstrate the skill. It allows the nurse to evaluate understanding, correct mistakes, and confirm safe self-care before discharge. Option 4 says, verbally repeat the instructions slowly before discharge. This is incorrect. Repeating instructions may help the client hear the information again, but it still does not verify understanding. The nurse needs the client to explain or demonstrate the instructions back. Now, here's the NCLEX alert. When NCLEX asks for the most effective teaching method, it often points to teach back or return demonstration. Teaching is not complete until the nurse evaluates understanding. Videos, handouts, and verbal teaching are helpful, but they do not confirm learning by themselves. For skills, choose Return Demonstration. The key takeaway is this: Teach Back confirms understanding, and Return Demonstration confirms skill performance. Client teaching should be interactive, not one way. The nurse should use simple language and reassess learning before discharge. Do not assume the client understands just because the client nods, says yes, or receives a handout. This concludes Section 1, Nursing Process, Healthcare Delivery, and Clinical Judgment. Now let's move into Section 2.
Section 2, Safety and Infection Control. In this section, we focus on one of the nurse's most important responsibilities, preventing harm before it happens. We'll cover standard precautions, transmission-based precautions, PPE, restraints, fire safety, electrical safety, poisoning response, incident reporting, seizure precautions, sharps safety, hand hygiene, and safe patient identification. These questions are high yield for the NCLEX because they test whether the nurse can recognize risk, choose the safest action, protect the client, and prevent infection or injury in real clinical situations. Question 9. Select all that apply. Contact precautions and PPE selection. Clinical scenario. The nurse is caring for a client with a healthcare-associated infection caused by methicillin-resistant Staphylococcus aureus, also called MRSA. The client is on contact precautions and has a colostomy. The nurse prepares to provide colostomy care. During the procedure, the nurse anticipates possible contact with stool and possible splashing of body fluids. And the question is asking, which personal protective equipment should the nurse obtain before providing colostomy care? Remember, this is SATA, so more than one option may be correct. The options are Option A, gloves. Option B, gown. Option C, goggles. Option D, surgical mask or face shield. Option E, shoe covers. Option F, N95 respirator. Take a moment and think about your answer. All right, let's break this down. The correct answers are Option A, gloves. Option B, gown. Option C, goggles. And Option D, surgical mask or face shield. The key idea here is that PPE depends on two things, the organism and the procedure. The organism is MRSA, which requires contact precautions. The procedure is colostomy care, which may involve stool and possible splashing of body fluids. So the nurse needs contact protection and splash protection. Now let's go through reasoning and logic behind each option. Option A, gloves. This is correct. Gloves are required for contact precautions and for any expected contact with stool, drainage, secretions, or contaminated surfaces. MRSA can spread through direct contact with the client or contaminated objects. Option B, gown. This is correct. A gown is required when direct contact with the client, colostomy appliance, stool, or contaminated linens is expected. Contact precautions commonly require gloves and gown. Option C, goggles. This is correct. Goggles protect the mucous membranes of the eyes. Because colostomy care can involve splashing of stool or body fluids, eye protection is needed. Option D, surgical mask or face shield. This is correct. A surgical mask or face shield protects the mouth, nose, and face from splashes. This is part of standard precautions when splashing of body fluids, secretions, or excretions is possible. Option E, shoe covers. This is incorrect. Shoe covers are not routinely required for contact precautions or standard colostomy care. They are used only in situations with heavy contamination risk, according to facility policy. Option F, N95 respirator. This is incorrect. An N95 respirator is used for airborne precautions, such as tuberculosis, measles, or varicella. MRSA requires contact precautions, not airborne precautions. Now here's the NCLEX alert. For NCLEX, remember that contact precautions usually require gloves and gown. Add eye and face protection if splashing is possible. MRSA is contact, not airborne, so do not choose an N95 respirator for routine MRSA care. Select only the PPE supported by the organism and the procedure. The key takeaway is this: PPE depends on both the organism and the procedure. MRSA means contact precautions. Colostomy care can create splash risk, so mucous membranes must be protected from body fluid exposure. Gloves, gown, goggles, and a surgical mask or face shield are appropriate here, but shoe covers are not routine PPE for standard colostomy care. Okay, let's move on to the next question. Question 10. NGN type matrix grid. Transmission-based precautions. Clinical scenario. The nurse is caring for 4 clients on a medical surgical unit. Client 1 is diagnosed with bacterial meningitis. Client 2 has suspected pulmonary tuberculosis. Client 3 has an MRSA wound infection with drainage. And Client 4 has influenza with coughing and fever. The nurse reviews the precautions needed for each client. And the question is asking, for each nursing action, identify whether the action is appropriate or requires intervention. This is a matrix grid question. You will look at each action and decide whether the precaution matches the client's infection and route of transmission. The nursing actions are: Option A. Place the client with bacterial meningitis in a private room or cohort with a client who has the same infection. Option B. Wear an N95 respirator before entering the room of a client with suspected pulmonary tuberculosis. Option C. Use gloves and gown when providing direct care to a client with draining MRSA wound infection. Option D. Place the client with suspected tuberculosis in a private negative pressure room. Option E. Instruct staff to wear a mask when transporting the client with meningitis outside the room. Option F. Wear a surgical mask when providing close care to the client with influenza. Option G. Use only standard precautions for the client with draining MRSA wound infection. Take a moment and think about your answer. All right, let's break this down. The correct answers are: Option A is appropriate, Option B is appropriate, Option C is appropriate, Option D is appropriate, Option E requires intervention, Option F is appropriate, and Option G requires intervention. The key idea here is to match the type of precaution to the route of transmission. Droplet infections need a surgical mask. Airborne infections need an N95 respirator and a negative pressure room. Contact infections need gloves and gown. Now let's go through each option. Option A says, place the client with bacterial meningitis in a private room or cohort with a client who has the same infection. This is appropriate. Bacterial meningitis is spread by respiratory droplets. A private room is preferred. If a private room is not available, cohorting with another client who has the same infection may be used according to facility policy. Option B says, wear an N95 respirator before entering the room of a client with suspected pulmonary tuberculosis. This is appropriate. Tuberculosis requires airborne precautions. The nurse should wear an N95 respirator or higher-level respiratory protection before entering the room. Option C says, use gloves and gown when providing direct care to a client with draining MRSA wound infection. This is appropriate. MRSA with wound drainage requires contact precautions. Gloves and gown help prevent transmission through direct contact with drainage, dressings, skin, linens, or contaminated surfaces. Option D says, place the client with suspected tuberculosis in a private negative pressure room. This is appropriate. Airborne infections require a private negative pressure room. This helps prevent infectious particles from spreading into the hallway or other care areas. Option E says, instruct staff to wear a mask when transporting the client with meningitis outside the room. This requires intervention. For droplet precautions, if transport is necessary, the client should wear a surgical mask when leaving the room. Staff use appropriate PPE during close care, but during transport, masking the client helps reduce droplet spread. Option F says, wear a surgical mask when providing close care to the client with influenza. This is appropriate. Influenza is spread by droplets. A surgical mask is used when the nurse is within close range of the client. Option G says, use only standard precautions for the client with draining MRSA wound infection. This requires intervention. Standard precautions apply to all clients, but draining MRSA requires additional contact precautions. Gloves and gown are needed for direct care. Now here is the NCLEX alert. For NCLEX, keep the routes straight. Meningitis and influenza mean droplet precautions. Tuberculosis means airborne precautions with an N95 respirator and a negative pressure room. MRSA wound drainage means contact precautions with gloves and gown. During transport for a droplet illness, the client wears the mask. Negative pressure rooms are for airborne infections, not droplet infections. The key takeaway is this: droplet precautions use a surgical mask. Airborne precautions use an N95 respirator with a negative pressure room, and contact precautions use gloves and gown. Private rooms or cohorting may be used for transmission-based precautions. Always match the PPE to the route of transmission. Okay, let's keep going. Question 11. NGN type highlight the text. Safe restraint application. Clinical scenario. The nurse obtains a prescription to apply soft wrist restraints to a confused client who is pulling at prescribed tubes. The nurse delegates the application of the restraints to an assistive personnel, or AP, and then observes the AP's actions. And the question is asking, highlight the action by the AP that requires further teaching. The observed AP actions are: the AP applies the restraint so that 2 fingers can fit between the restraint and the client's skin. The AP uses a quick-release safety knot on the restraint straps. The AP secures the restraint straps to the side rails of the bed. The AP applies restraint straps that do not tighten when the client pulls against them. Take a moment and think about your answer. All right, let's break this down. The correct statement to highlight is, the AP secures the restraint straps to the side rails of the bed. Now let's go through deduced logic behind each observed action. The first action says, the AP applies the restraint so that 2 fingers can fit between the restraint and the client's skin. This is a correct action. The restraint should be secure enough to prevent unsafe movement, but loose enough to avoid impaired circulation, skin injury, or nerve compression. The second action says, the AP uses a quick-release safety knot on the restraint straps. This is also correct. A quick-release knot, or an approved quick-release device, allows the restraint to be removed quickly in an emergency. The restraint should never be tied in a way that delays removal. The third action says, the AP secures the restraint straps to the side rails of the bed. This is the unsafe action. Restraints are attached to a stable part of the bed frame, never to the side rails. Side rails move up and down, so attaching restraints to them can cause the restraint to tighten or pull when the rail is lowered. The fourth action says, the AP applies restraint straps that do not tighten when the client pulls against them. This is a correct action. Restraints should not become tighter when the client moves or pulls. Tightening can impair circulation, damage skin, compress nerves, or cause injury. Now, here is the NCLEX alert. For NCLEX, remember that restraints are secured to the bed frame, never the side rails. Use a quick-release knot or an approved quick-release device. Check circulation, skin, and comfort after application. Restraints are used only when less restrictive measures are ineffective. And when the question says, requires further teaching, your job is to find the unsafe action. The key takeaway is this: restraints are a safety measure, not punishment or convenience. Attach restraints to a stable bed frame, leave enough space for circulation, and reassess the continued need for restraints regularly. Even when restraint care is delegated, the nurse remains responsible for safe application, monitoring, and follow-up. Okay, let's move on to the next one. Question 12. NGN type drop-down close, restraint monitoring and release. Clinical scenario. The nurse is caring for a confused client who has soft wrist restraints prescribed after repeatedly pulling at a newly placed nasogastric tube. The nurse delegates routine care tasks to the assistive personnel, or AP, but remains responsible for client assessment and safety. The nurse gives instructions about restraint care, and the question is asking you to complete each statement by choosing the correct option from the drop-down menu. You will decide the correct timing for restraint release, the correct activity when restraints are released, the correct assessment distal to the restraint, and the correct place to secure restraint straps. The first statement is, restraints should be released at least every dash. The second statement is, when restraints are released, the AP should assist with dash. The third statement is, the nurse should assess skin integrity and blank distal to the restraint. The fourth statement is, restraint straps should be secured to the dash. Take a moment and think about your answer. Consider all options, but pick the right one. Now let's go through the reasoning. First, restraints should be released at least every 2 hours, or according to facility policy. This allows movement, promotes circulation, and reduces the risk of skin breakdown, stiffness, injury, and emotional distress. Every 4 hours or every 6 hours would be too long. Leaving restraints in place too long increases the risk for impaired circulation, decreased mobility, pressure injury, and client distress. Second, when restraints are released, the AP should assist the client with range of motion exercises. Range of motion exercises help maintain joint mobility, muscle activity, and circulation while the client's movement is restricted. Medication administration would not be delegated to the AP. Documentation may be part of reporting routine care depending on policy, but the activity the AP assists with when restraints are released is range of motion. Third, the nurse should assess skin integrity and circulation distal to the restraint. Distal means farther away from the center of the body, below the restraint. The nurse should assess skin color, temperature, pulses, sensation, movement, and skin condition near and below the restraint. Tight restraints can impair blood flow, compress nerves, or damage skin. Appetite and bowel sounds may be important in other assessments, but they do not answer what must be assessed distal to the restraint. Fourth, restraint straps should be secured to the bed frame, not the side rails. This is a major safety point. If restraints are attached to the side rails and the rails are lowered, the restraint can tighten, pull the client, or place the client in an unsafe position. Restraints should never be attached to side rails or to a call light cord. Now, here is the NCLEX alert. For NCLEX, remember that restraints are released at least every 2 hours. Assess circulation and skin under and around the restraints. Attach restraints to the bed frame, never the side rails. The AP may assist with routine care, but the nurse is responsible for assessment and evaluation. And always use the least restrictive safety measure first. The key takeaway is this: restraints require frequent monitoring. Release restraints for range of motion and circulation. Check skin and neurovascular status. Follow facility policy and the provider prescription. Restraints should never be used for staff convenience, punishment, or routine control. Okay, let's move on to the next question. Question 13. Ordered response, fire safety, and race sequence. Clinical scenario. The nurse enters a client's room and sees smoke coming from a wastebasket. A small fire is visible in the wastebasket near the wall. The client is lying in bed and is awake. The nurse immediately assists the client out of the room. And the question is asking, place the nurse's next actions in the correct order. The actions are, extinguish the fire if it is safe to do so, activate the fire alarm, confine the fire by closing the room door, rescue the client from immediate danger. Take a moment and think about the correct sequence. All right, let's break this down. The correct order is 4, 2, 3, 1. So the sequence of action is rescue the client from immediate danger, activate the fire alarm, confine the fire by closing the room door, extinguish the fire if it is safe to do so. This follows the fire safety acronym RACE. R means rescue, A means alarm, C means confine, and E means extinguish, if safe. The first action is to rescue the client from immediate danger. Client safety comes first. Any client in immediate danger from smoke or fire should be moved to a safe location before anything else. The second action is to activate the fire alarm. After the client is safe, the nurse activates the alarm. This alerts staff and starts the facility's emergency response. The third action is to confine the fire by closing the room door. Closing the door helps contain smoke and fire, slows the spread, and protects other clients and staff. The fourth action is to extinguish the fire if it is safe to do so. The nurse may attempt to extinguish a small fire only after the client is rescued, the alarm is activated, and the fire is confined. The nurse should never place themselves at risk to fight a fire. Now here is the NCLEX alert. Fire response follows RACE. Rescue comes before alarm when a client is in immediate danger. Do not choose extinguish first unless rescue, alarm, and confinement have already been addressed. Close doors to confine smoke and fire. And remember, nurse safety matters. Do not fight a large or spreading fire. The key takeaway is this. R is rescue, A is alarm, C is confine, and E is extinguish if safe. Client safety comes before equipment, property, or trying to put out the fire. Okay, let's keep building clinical judgment and move on to Question 14, multiple choice, electrical safety with equipment. Clinical scenario. The nurse is preparing to start an IV infusion containing potassium chloride using an electronic infusion pump. When the nurse attempts to plug in the pump, all wall outlets near the client's bed are already in use. And the question is asking, which action should the nurse take? The options are, Option 1, start the IV infusion without using the infusion pump. Option 2, contact the electrical maintenance department or appropriate facility support for assistance. Option 3, plug the infusion pump into an available outlet located above the sink. Option 4, use a regular extension cord from the nurse's station to power the pump. Take a moment and think about your answer. All right, let's break this down. The correct answer is Option 2. Now, let's go through the reasoning. Option 1 says, start the IV infusion without using the infusion pump. This is incorrect. Potassium chloride must be administered carefully and at a controlled rate. Starting the infusion without a pump increases the risk for rapid infusion, medication error, and serious cardiac complications. Option 2 says, contact the electrical maintenance department or appropriate facility support for assistance. This is correct. This action uses the proper facility resource to solve an electrical safety problem. Medical equipment must be powered safely to prevent shock, fire, overload, or equipment malfunction. Option 3 says, plug the infusion pump into an available outlet located above the sink. This is incorrect. Electrical equipment should not be plugged in near water sources. A sink increases the risk for electrical shock, especially if water splashes or the cord becomes wet. Option 4 says, use a regular extension cord from the nurse's station to power the pump. This is incorrect. Regular extension cords are not safe for medical equipment. They can create fire hazards, tripping hazards, and overload risks. Hospital-approved equipment and facility support should be used instead. Now, here is the NCLEX alert. Never use unsafe shortcuts with electrical equipment. Avoid plugging equipment near sinks or water. Do not use regular extension cords for medical devices. Potassium chloride IV requires controlled infusion, usually by pump. When equipment setup is unsafe, use facility resources. The key takeaway is this: electrical safety is part of client safety. Medical equipment must be properly grounded and safely powered. IV potassium is high risk and needs controlled administration. The safest answer often avoids improvising with equipment. Call the correct department when equipment or outlet safety is an issue. Okay, let's keep building clinical judgment and move on to the next question. Question 15. NGN type bow tie. Pediatric poisoning response. Clinical scenario. A nurse receives a phone call from a parent who says, "My 3-year-old swallowed some liquid furniture polish about 10 minutes ago." The parent reports that the child is awake, crying, and coughing occasionally, but is breathing without difficulty. The bottle label lists petroleum distillates as an ingredient. The parent asks, "Should I make my child throw up?" And the question is asking you to complete the bow tie by selecting 3 things. First, 1 priority nursing instruction. Second, 2 pieces of information the nurse should tell the parent to have ready. And third, 2 actions the parent should avoid. For the priority nursing instruction, the options are: Option A, induce vomiting immediately to remove the substance. Option B, call the Poison Control Center now for substance-specific instructions. Option C, give the child milk to dilute the furniture polish. Option D, drive the child to the emergency department without calling anyone first. For information to have ready, the options are: Option E, the exact product name and ingredients listed on the label. Option F, the child's usual bedtime routine. Option G, the estimated amount swallowed and time of ingestion. Option H, the parent's preferred pharmacy. For actions to avoid, the options are: Option 1, making the child vomit unless specifically instructed. Option J, keeping the product container available for reference. Option K, giving food, fluids, or home remedies unless instructed. Option L, watching the child's breathing while waiting for instructions. Take a moment and think about your answer. All right, let's break this down. For the priority nursing instruction, the correct answer is option B. Call the Poison Control Center now for substance-specific instructions. This is the priority because the child is currently awake and breathing without difficulty, so the situation is stable enough to call poison control first. Poisoning care depends on the exact substance, amount swallowed, time of ingestion, the child's age and weight, and the child's symptoms. Option A is unsafe because inducing vomiting can increase aspiration risk, especially with petroleum products. Option C is incorrect because the nurse should not recommend milk, food, fluids, or home remedies unless poison control gives that instruction. Option D is not the best first step because emergency care may be needed, but poison control gives immediate substance-specific guidance when the child is stable. For the information to have ready, the correct answers are option E and option G. The parent should have the exact product name and ingredients from the label, plus the estimated amount swallowed and the time of ingestion. These details help poison control determine the toxicity risk and next steps. The child's bedtime routine and the parent's preferred pharmacy are not priority information for immediate poisoning response. For the actions to avoid, the correct answers are option 1 and option K. The parent should avoid making the child vomit unless specifically instructed, and should avoid giving food, fluids, or home remedies unless instructed. These actions can worsen symptoms, increase aspiration risk, or delay correct care. Keeping the product container available is actually appropriate because poison control may need the label information. Watching the child's breathing is also appropriate while waiting for instructions. Now here is the NCLEX alert. Poison control is the priority if the child is currently stable. But if airway, breathing, or consciousness is compromised, activate emergency response. Never induce vomiting unless specifically instructed. The product label, amount swallowed, and time of ingestion are key cues. The key takeaway is this: poisoning care is substance-specific. Petroleum products increase aspiration risk. Avoid home remedies unless instructed. For a stable ingestion, call poison control first. For an unstable child, emergency response comes first. Okay, let's keep building clinical judgment and nursing insight. Question 16. Highlight the text. Factual incident and occurrence report documentation. Clinical scenario. The nurse hears a client call out for help from the room. When the nurse enters, the client is lying on the floor beside the bed. The bed alarm is sounding, and the client's walker is near the doorway. The nurse assesses the client, assists the client back to bed with help, notifies the healthcare provider, and completes an occurrence report according to facility policy. And the question is asking, highlight the statement that is most appropriate for the nurse to include in the occurrence report. The documentation options are: the client fell while trying to get out of bed without assistance. The client climbed over the side rail and landed on the floor. The client was found lying on the floor beside the bed at 06:45. The client became restless and refused to follow fall prevention instructions. Take a moment and think about your answer. The correct statement to highlight is: the client was found lying on the floor beside the bed at 06:45. All right, let's discuss the rationale behind. This is the best documentation because it is factual, objective, and based on what the nurse actually observed. The nurse knows the client was found on the floor beside the bed at 06:45. The nurse does not know exactly how the client got there unless the event was witnessed. The first option is incorrect because it assumes the client fell while trying to get out of bed without assistance. That may be possible, but it was not directly observed. The second option is incorrect because it assumes the client climbed over the side rail and landed on the floor. Again, unless the nurse witnessed that action, it should not be documented as fact. The third option is correct because it uses neutral, observable wording, found lying on the floor beside the bed at 06:45. The fourth option is incorrect because it uses judgmental and vague wording. Words like restless and refused should be avoided unless they are supported by specific behaviors or exact client statements. Now, here is the NCLEX alert. For NCLEX, document what was seen, heard, measured, or done. Do not document assumptions about how an event happened. Avoid blaming words like refused, non-compliant, careless, or restless unless they are supported by facts. Occurrence reports are completed according to facility policy, but they are not used to blame the client or staff. And in the medical record, do not write "incident report completed." The key takeaway is this: factual documentation protects the client and the nurse. Unwitnessed events require objective wording. Found on the floor is safer than fell out of bed. Document assessment findings and actions taken. Legal documentation should be specific, neutral, and observable. Okay, let's move on to the next. Question 17. Matrix grid. Sharp safety and needle stick prevention. Clinical scenario. The nurse is supervising a newly hired nurse and an assistive personnel during morning care on a medical surgical unit. Several clients require blood glucose checks, insulin administration, and blood specimen collection. The nurse evaluates whether infection control and sharp safety practices are being followed correctly. And the question is asking, for each action, identify whether the action is safe practice or requires intervention. The actions include activating a needle safety device after injection, recapping a used insulin needle, placing a used lancet into the sharps container, carrying an uncapped used needle across the room, wearing gloves during a fingerstick blood glucose check, pushing down items inside a sharps container, and responding to a needle stick injury. Take a moment and think about your answer. All right, let's break this down. The safe practices are: option A, activating the needle safety device immediately after administering an injection. Option C, placing a used lancet directly into the sharps container after a blood glucose check. Option E, wearing gloves when performing a fingerstick blood glucose check. And option G, washing the area and reporting the exposure after a needle stick injury. The actions that require intervention are option B, recapping a used insulin needle before carrying it to the sharps container. Option D, carrying an uncapped used needle across the room to dispose of it after finishing documentation. And option F, pushing down on items inside a sharps container to make more room. Let's look at the rationales. For option A, the main safety rule here is simple. Used sharps should be handled as little as possible and disposed of immediately at the point of use. So, when the nurse activates the safety device right after an injection, that is safe practice. Safety-engineered devices are designed to reduce accidental needle stick injury, but they must be activated right away. For option B, recapping a used insulin needle requires intervention. Used needles should not be recapped because recapping creates a direct risk for needle stick injury. The needle should go directly into an approved sharps container. For option C, placing a used lancet directly into the sharps container is safe practice. Lancets are sharps, and they must be discarded in a puncture-resistant sharps container immediately after use. For option D, carrying an uncapped used needle across the room requires intervention. The nurse should not finish documentation first, and the nurse should not carry an exposed sharp around the room. Disposal should happen immediately at the point of use. Rationale for option E. Wearing gloves during a fingerstick blood glucose check is safe practice because blood exposure is expected. Gloves reduce contact with blood and body fluids, but remember, gloves do not prevent puncture injuries. For option F, pushing down on items inside a sharps container requires intervention. The nurse should never reach into, compress, or push down the contents of a sharps container. This creates a high risk for puncture injury. For option G, after a needle stick injury, washing the area and reporting the exposure is safe practice. The nurse should wash the area with soap and water, report the exposure, and follow the facility's post-exposure protocol. Now, here is the NCLEX alert. Do not recap used needles. Dispose of sharps immediately at the point of use. Never push down contents inside a sharps container. After a needle stick injury, wash the area, report the exposure, and follow the exposure protocol. Gloves reduce blood exposure, but they do not prevent needle punctures. The key takeaway is this. Sharps safety prevents bloodborne pathogen exposure. Lancets, needles, and used injection devices go in sharps containers. Safety devices should be activated immediately after use. Sharps containers should not be overfilled or manually compressed. The nurse must intervene whenever unsafe sharps handling is observed. Okay, let's keep building clinical judgment and move on to the next. Question 18. Matrix Grid. Patient Identification and Elopement Prevention. Clinical scenario. The nurse is caring for an older adult client admitted with a urinary tract infection. The client is intermittently confused, gets out of bed without calling, and has wandered toward the unit exit twice during the shift. The client is scheduled for morning medications and a diagnostic test. The nurse reviews safety actions with a newly hired nurse. And the question is asking, for each nursing action, identify whether the action is safe practice or requires intervention. The actions include verifying the client's full name and date of birth, identifying the client by room number, placing the call light within reach and activating the bed alarm, applying wrist restraints before trying other measures, notifying the charge nurse about elopement risk, confirming the identification band before transport, and giving vague instructions to the assistive personnel. Take a moment and think about your answer. All right, let's break this down. The safe practices are, option A, verifying the client's full name and date of birth before medication administration. Option C, placing the call light within reach and activating the bed alarm. Option E, notifying the charge nurse that the client is at risk for elopement and may need closer observation. And option F, confirming the client's identification band before sending the client for the diagnostic test. The actions that require intervention are: option B, identifying the client by room number before transport arrives. Option D, applying wrist restraints to prevent wandering without trying other safety measures first. And option G, telling the assistive personnel to just keep an eye on the client without explaining the elopement risk. Let's look at the rationales. For option A, verifying the client's full name and date of birth is safe practice. The nurse should use at least 2 approved client identifiers before medications, procedures, treatments, specimens, and transport. Full name and date of birth are appropriate identifiers. For option B, identifying the client by room number requires intervention. Room number is not an acceptable client identifier. Clients can change rooms, beds, or units. Using a room number increases the risk for wrong client errors. For option C, placing the call light within reach and activating the bed alarm is safe practice. This supports fall prevention and elopement prevention. A confused client who gets out of bed without calling needs environmental safety measures and early warning systems. For option D, applying wrist restraints without trying other safety measures first requires intervention. Restraints are not the first intervention for wandering or elopement risk. The nurse should use the least restrictive measures first, such as reorientation, close observation, alarms, a safe environment, and team communication. For option E, notifying the charge nurse about elopement risk is safe practice. Elopement risk requires team communication. The charge nurse can help arrange closer monitoring, room placement near the nurse's station, frequent checks, or facility-approved elopement precautions. For option F, confirming the client's identification band before the diagnostic test is safe practice. Client identification must be verified before transport and procedures. The nurse should match the identification band with the order or transport request. For option G, telling the assistive personnel to just keep an eye on the client requires intervention. This instruction is too vague. Delegation requires clear communication. The AP should know that the client is confused, at risk for wandering, and must be reported immediately if attempting to leave the unit. Now here is the NCLEX alert. Use 2 identifiers, never the room number. Confirm identity before medications, procedures, specimens, and transport. Elopement risk requires team communication and prevention. Restraints are not first line for wandering, and vague delegation is unsafe. The key takeaway is this: wrong client errors are preventable safety events. Confusion, infection, and wandering increase elopement risk. Least restrictive safety measures come before restraints. Identification bands must match orders before procedures or transport. Safety plans must be communicated clearly to the team, including during shift report. Notify the charge nurse or provider and request closer observation or one-to-one supervision if the client is unsafe. Use facility-approved elopement precautions such as bed alarms, wander alert devices, exit alarms, or secured door systems. Okay, let's keep building good nursing practices and move on to the next one. Now, let's move into Section 3, Management of Care, Delegation, and Prioritization. This is one of the strongest and most important sections in fundamentals because it tests how nurses make safe decisions when multiple clients, tasks, and risks are happening at the same time. In this section, we'll focus on the safe and effective care environment, RN, LPN, and UAP roles, delegation, stable versus unstable clients, predictable versus unpredictable outcomes, ABCs, Maslow, acute versus chronic problems, expected versus unexpected findings, triage, team nursing, and safe assignment. As you move through these questions, keep asking, who is unstable? What is the priority? What can be delegated? What must the nurse do? And which action keeps the client safest right now? Question 19. Multiple choice. ABC priority. Breathing concern first. Clinical scenario. The nurse receives morning report for 4 clients on a medical surgical unit. All 4 clients have scheduled care needs during the first hour of the shift. And the question is asking, which client should the nurse assess first? The options are: Option 1. A post-operative client who is being discharged today and needs teaching about a new oral antibiotic. Option 2. A client with a recent abdominal incision who is due for a scheduled dressing change. Option 3. A client with a newly inserted nasogastric tube who is waiting for a chest X-ray to confirm placement before use. Option 4. A client with asthma who requested a breathing treatment during the night shift and has not yet been reassessed. Take a moment and think about your answer. The correct answer is option 4. All right, let's break this down. A client with asthma who requested a breathing treatment during the night shift and has not yet been reassessed. This client should be assessed first because asthma involves airway and breathing. A request for a breathing treatment may indicate shortness of breath, bronchospasm, wheezing, or worsening respiratory status. The key phrase is, has not yet been reassessed. That means a breathing concern may still be unresolved. Using ABCs, breathing concerns come before routine teaching, scheduled dressing changes, and stable waiting tasks. Let's look why other options are incorrect. Option 1 is incorrect. Discharge teaching about a new oral antibiotic is important, but teaching is not the first priority when another client may have an unresolved breathing problem. Option 2 is incorrect. A scheduled dressing change is important, but it is usually not the highest priority unless there are signs of active bleeding, wound dehiscence, infection, or severe pain. Option 3 is incorrect. Confirming nasogastric tube placement before use is a safety priority, but the tube is already waiting for X-ray confirmation and should not be used yet. This does not take priority over a possible breathing problem. Now, here is the NCLEX alert. Use ABCs when deciding who to assess first. Breathing problems usually outrank teaching, dressing changes, and routine tasks. Requested a breathing treatment is a clue for possible respiratory distress. Unreassessed symptoms from a previous shift can signal delayed care. Stable scheduled care is not first when another client may be unstable. The key takeaway is this: airway and breathing are top priorities. Asthma can worsen quickly without reassessment. Discharge teaching is usually lower priority than physiologic instability. Scheduled tasks do not outrank acute respiratory concerns. The nurse should assess the client with the greatest risk first. Okay, let's keep building clinical judgment and move on to the next. Question 20. Highlight the text. ED triage, chest pain priority. Clinical scenario. The nurse is working triage in the emergency department during a busy evening shift. 4 clients arrive within a few minutes of each other, and the question is asking, highlight the client statement or finding that requires the highest priority assessment and treatment. The triage notes are, Client A says, I have body aches and a headache. The client reports a history of seizures, but is awake, alert, and speaking clearly. Client B says, I twisted my ankle while rollerblading. The ankle is swollen, and the client is requesting pain medication. Client C says, I cut my index finger while cooking. The laceration is small and bleeding is controlled with pressure. Client D says, I have chest pain, but I think it is just from spicy pizza I ate earlier. The client reports chest pressure that has not fully resolved. Take a moment and think about your answer. The correct statement to highlight is from Client D. I have chest pain, but I think it is just from spicy pizza I ate earlier. The client reports chest pressure that has not fully resolved. All right, let's see rational. This client requires the highest priority assessment and treatment. Chest pain or chest pressure is treated as emergent until myocardial infarction or another life-threatening cause is ruled out. The important trap here is that the client is trying to explain the pain as spicy food or indigestion. But the nurse should not accept the client's self-diagnosis as reassurance. Unresolved chest pressure may indicate a circulation problem, including cardiac ischemia, and requires immediate assessment. Now let's look at the other clients. Client A reports body aches and a headache with a history of seizures. This client does need assessment, especially because of the seizure history. But right now, the client is awake, alert, and speaking clearly. There is no immediate airway, breathing, circulation, or acute neurologic emergency described. Client B has a swollen ankle after twisting it while rollerblading. This client may have a sprain or fracture and needs pain control and evaluation. But this is not the highest priority unless there are signs of neurovascular compromise, severe deformity, or loss of circulation. Client C has a small finger laceration with bleeding controlled by pressure. This is a lower priority condition. A minor laceration with controlled bleeding can usually wait while higher acuity clients are assessed. Now, here is the NCLEX alert. Chest pain is priority until myocardial infarction is ruled out. Do not accept the client's self-diagnosis as reassurance. Triage is based on severity, instability, and ABCs, not who arrived first. Chest pain, severe respiratory distress, stroke symptoms, and major trauma are emergent. Minor cuts, sprains, and stable symptoms can usually wait. The key takeaway is this: ED triage identifies who needs care first, not who arrived first. Chest pressure is a circulation warning sign. I think it is indigestion does not rule out cardiac ischemia. Stable pain complaints are lower priority than possible cardiac symptoms. The safest NCLEX answer treats chest pain as emergent. Okay, let's keep building clinical judgment and move on to the next. Question 21. NGN type bow tie. Delegation to AP or PSW. Clinical scenario. The registered nurse is planning morning assignments for an assistive personnel, or PSW, on a medical surgical unit. The AP, or PSW, has been trained in routine hygiene care, vital signs, intake and output, specimen collection, and reporting abnormal findings to the nurse. The nurse reviews the following client care needs. A client requires a scheduled colostomy irrigation. A client is receiving continuous tube feedings through a nasogastric tube. A client needs a clean catch urine specimen collected. And a client has difficulty swallowing food and fluids. And the question is asking you to complete the bow tie by selecting 3 things. First, 1 most appropriate task to delegate. Second, 2 reasons this task is appropriate. And third, 2 tasks the RN should not delegate to the AP or PSW. For the most appropriate task to delegate, the options are: Option A, perform a scheduled colostomy irrigation. Option B, manage a client receiving continuous tube feedings. Option C, collect a clean catch urine specimen. Option D, feed a client who has difficulty swallowing. For the reasons this task is appropriate, the options are: Option E, the task is routine, non-invasive, and has a predictable outcome. Option F, the task requires assessment of bowel function and stoma response. Option G, the AP or PSW can collect the specimen and report abnormal findings to the nurse. Option H, the AP or PSW can independently decide whether the specimen is clinically significant. For the tasks the RN should not delegate, the options are: Option 1, colostomy irrigation. Option J, routine urine specimen collection. Option K, care of a client with swallowing difficulty during meals. Option L, reporting that a urine specimen could not be obtained. Take a moment and think about your answer. For the most appropriate task to delegate, the correct answer is Option C, collect a clean catch urine specimen. All right, let's look at the rationale. Routine clean catch urine specimen collection is appropriate for an AP or PSW when the client is stable and the staff member has been trained. This task is routine, non-invasive, and has a predictable outcome. Option A is not the best task because colostomy irrigation is an invasive procedure that requires nursing assessment, monitoring, and possible teaching. Option B is not the best task because continuous tube feeding requires nursing judgment, monitoring for aspiration, tube placement concerns, intolerance, and complications. Option D is not appropriate because difficulty swallowing creates an aspiration risk. A client with dysphagia needs careful assessment, precautions, and monitoring. For the reasons this task is appropriate, the correct answers are Option E and Option G. Option E is correct because the task is routine, non-invasive, and predictable. Option G is correct because the AP or PSW can collect the specimen and report abnormal findings or problems to the nurse. The key point is that the AP or PSW may collect and report, but the RN evaluates and decides what the findings mean. Option F is incorrect because assessment of bowel function and stoma response describes nursing judgment. That is why colostomy irrigation should not be delegated. Option H is incorrect because the AP or PSW cannot independently decide whether a specimen is clinically significant. Interpretation and decision-making belong to the RN. For the tasks the RN should not delegate, the correct answers are Option 1 and Option K. Option 1, colostomy irrigation, should not be delegated because it is invasive and requires assessment, monitoring, and nursing judgment. Option K, care of a client with swallowing difficulty during meals, should not be delegated because dysphagia increases the risk for aspiration. Option J is incorrect because routine urine specimen collection can be delegated when the client is stable and the AP or PSW is trained. Option L is also incorrect because reporting that a urine specimen could not be obtained is appropriate. Reporting observations and task problems is expected from AP or PSW staff. Now here is the NCLEX alert. Delegate routine, stable, predictable, non-invasive tasks. Do not delegate assessment, teaching, evaluation, or nursing judgment. Dysphagia is an aspiration risk and requires caution. Invasive procedures are usually not appropriate for AP or PSW delegation. The RN remains accountable for supervision and follow-up. The key takeaway is this: AP or PSW staff can collect routine urine specimens. The RN keeps tasks involving instability, aspiration risk, invasive care, teaching, assessment, or clinical judgment. Reporting findings is allowed, but interpreting findings is the RN's role. Use the right task, right person, and right circumstance when deciding what can be safely delegated. Moving on, Question 22, Matrix Grid. Assigning stable client care to LPN or RPN. Clinical scenario. The charge nurse is planning assignments in a long-term care unit. The team includes 1 RN, 1 LPN or RPN, and 3 assistive personnel or PSWs. The nurse must match each client care need with the most appropriate team member based on stability, predictability, task complexity, and required nursing judgment. And the question is asking, for each client care need, select the most appropriate team member. The care needs include a complete bed bath and linen change, routine ambulation after meals, hourly vital signs after a routine medication change, scheduled abdominal wound irrigation and dressing changes, a new change in level of consciousness with oxygen saturation of 88%, and a new surgical wound that suddenly feels like it has opened up. Take a moment and think about your answer. The care needs appropriate for the AP or PSW are: Option A, a stable client requires a complete bed bath and linen change. Option B, an older adult client requires routine ambulation in the hallway after meals. And Option C, a stable client requires hourly vital signs after a routine medication change, with results reported to the nurse. The care need appropriate for the LPN or RPN is Option D. A stable client requires scheduled abdominal wound irrigation and dressing changes every 3 hours. The care needs that require the RN are Option E. A client has a new change in level of consciousness and oxygen saturation of 88%. And option F, a client with a new surgical wound suddenly reports that the incision opened up. All right, let's look at the rationales. For option A, a complete bed bath and linen change is appropriate for the assistive personal or personal support worker. This is routine, non-invasive care for a stable client. It does not require nursing judgment, teaching, or assessment. For option B, routine ambulation after meals is also appropriate for the AP or PSW. Assisting a stable client with routine ambulation is within the usual role of assistive personnel. The AP or PSW should report dizziness, weakness, shortness of breath, pain, or refusal to ambulate to the nurse. For option C, hourly vital signs with reporting is appropriate for the AP or PSW. The AP or PSW may collect routine data, such as vital signs, when the client is stable. But the nurse is responsible for interpreting abnormal findings and deciding what action is needed. For option D, scheduled abdominal wound irrigation and dressing changes are appropriate for the LPN or RPN. This is more complex than AP or PSW care, but if the client is stable and the outcome is predictable, the LPN or RPN may provide routine nursing care according to scope of practice and facility policy. For option E, a new change in level of consciousness with oxygen saturation of 88% requires the RN. This client is unstable. A new neurologic change plus low oxygen saturation may indicate airway, breathing, or neurologic deterioration. The RN must assess the client, prioritize interventions, notify the provider if needed, and evaluate the response. For option F, a surgical wound that suddenly opened up also requires the RN. This may indicate wound dehiscence or evisceration. That is a new and potentially serious complication requiring immediate assessment, clinical judgment, and urgent intervention. Now, here is the NCLEX alert. For NCLEX, remember the assignment pattern. AP or PSW staff can perform routine, non-invasive tasks for stable clients. LPN or RPN staff can care for stable, predictable clients who need routine nursing care. The RN keeps unstable clients, new findings, assessment, teaching, evaluation, and urgent interventions. Vital signs can be delegated, but interpretation stays with the nurse. New respiratory, neurologic, or wound complications require RN assessment. The key takeaway is this: delegation and assignment depend on client stability and task complexity. LPN or RPN assignments should be predictable and within scope. AP or PSW staff may collect data, but they do not interpret the clinical meaning. The RN keeps care that requires assessment, judgment, teaching, evaluation, or urgent intervention. A stable wound dressing may fit LPN or RPN care, but a newly opened wound requires RN care. Okay, let's keep building clinical judgment and move on to the next one. Question 23. Select all that apply. Delegation decision factors. Clinical scenario. The charge nurse is planning assignments for the day on a medical surgical unit. The team includes 1 RN, 1 LPN or RPN, and 2 assistive personnel or PSWs. Several clients have changing care needs, including new admissions, wound care, routine hygiene, blood glucose checks, and possible discharges. And the question is asking, which factors should the charge nurse use when deciding what tasks can be safely delegated? Remember, this is SATA, so more than one option may be correct. The options are: Option A, the acuity and stability of each client. Option B, the skill level, training, and scope of the team member. Option C, the staff member's preference for certain clients. Option D, whether the task requires assessment, teaching, judgment, or evaluation. Option E, the convenience of assigning rooms that are close together. Option F, the client's needs and the worker's ability to meet those needs safely. Option G, whether clear directions and follow-up supervision can be provided. Option H, the number of discharges expected later in the shift. Take a moment and think about your answer. The correct answers are Option A, Option B, Option D, Option F, and Option G. All right, let's look at the rationales. For Option A, acuity and stability are correct delegation factors. Client safety comes first. Stable, predictable clients are usually more appropriate for delegation than unstable clients or clients with new, changing, or complex findings. For Option B, the skill level, training, and scope of the team member are also correct. The charge nurse must match the task to the person. This means considering the team member's role, training, experience, competency, and legal scope of practice. For Option C, staff preference is not a correct primary delegation factor. A staff member may prefer certain clients, but preference should never override client acuity, staff competency, or safe assignment. For Option D, whether the task requires assessment, teaching, judgment, or evaluation is correct. These are RN responsibilities. Tasks that require nursing assessment, teaching, clinical judgment, or evaluation should not be delegated to AP or PSW staff. For Option E, room convenience is not a correct safety factor. Room location may help organize workflow, but convenience is not the basis for safe delegation. Client condition and team member ability matter more. For Option F, matching the client's needs with the worker's ability is correct. A task may be safe for one team member, but unsafe for another, depending on the client's condition, the worker's training, and the complexity of the task. For Option G, clear directions and follow-up supervision are correct. Delegation requires clear communication, expected reporting, and follow-up supervision. The RN remains accountable for appropriate delegation and evaluation of outcomes. For Option H, the number of expected discharges is not a core delegation factor. Discharges affect workload planning, but they do not determine whether a task itself can be safely delegated. Now, here is the NCLEX alert. Delegate based on safety, not convenience. Keep assessment, teaching, judgment, and evaluation with the RN. Match the task to the client's condition and the staff member's scope. Stable and predictable usually means more appropriate for delegation. The RN remains responsible for supervision and follow-up. The key takeaway is this: safe delegation uses the right task, right person, right circumstance, right direction, and right supervision. Client acuity is more important than room location or staff preference. AP or PSW staff can perform routine tasks, but they do not make clinical judgments. LPN or RPN assignments should involve stable, predictable nursing care. The charge nurse must balance client needs with team member ability. Okay, let's keep building nursing insights and move on to the next one. Question 24. Matrix Grid. Team Nursing Model. Clinical Scenario. A newly hired nurse is attending orientation on nursing care delivery models. The educator explains that the facility uses different models depending on staffing, client needs, and unit workflow. The nurse reviews examples of care delivery models. And the question is asking, for each scenario, identify the nursing care delivery model being described. The care delivery models are team nursing, functional nursing, primary nursing, and case management. The scenarios include an RN leading LPN, or RPNs and AP, or PSWs for a group of clients, staff members dividing care by tasks, one RN coordinating total care, and a nurse coordinating discharge needs and community resources. Take a moment and think about your answer. The correct answers are: Option A is team nursing. Option B is functional nursing. Option C is primary nursing. And Option D is case management. All right, let's look at the rationales. For Option A, An RN leads 2 LPN or RPNs and 3 AP or PSWs in caring for a group of 12 clients. This describes team nursing. Team nursing uses a team leader, usually an RN, who coordinates care delivered by nursing staff with different roles and skill levels. The clue is that the RN leads a group of staff caring for a group of clients. For option B, one staff member gives all baths, another takes all vital signs, and another administers medications for a group of clients. This describes functional nursing. Functional nursing divides care by task. Each staff member performs one specific function for many clients. The clue is task-based care. For option C, one RN is responsible for planning and coordinating the total care of assigned clients during the hospital stay. This describes primary nursing. Primary nursing gives one RN responsibility for planning and coordinating the client's overall nursing care. The clue is one RN responsible for total care planning. For option D, a nurse coordinates discharge needs, home care, equipment, and community resources for a client with complex needs. This describes case management. Case management focuses on coordination of services, discharge planning, resources, and continuity of care. The clue is connecting the client with services beyond the immediate bedside care. Now, here is the NCLEX alert. Team nursing means the RN leads a group of staff caring for a group of clients. Functional nursing means task-based care. Primary nursing means one RN is responsible for total care planning. Case management means coordination, discharge planning, resources, and continuity of care. The key takeaway is this: team nursing depends on communication and RN leadership. The RN team leader coordinates assignments and supervises care. Functional nursing is efficient but can feel task-focused. Case management connects the client with resources after discharge. On NCLEX, watch for wording clues like RN leads a team, tasks are divided, one RN plans total care, or discharge resources are coordinated. Great work, let's keep going. Question 25. Drop-down close, floating and safe assignment. Clinical scenario. The nurse arrives for a scheduled shift on a medical surgical unit and is told to float to the intensive care unit because the ICU is short-staffed. The nurse has never worked in the ICU and has not received ICU-specific orientation. The nurse is concerned about accepting an assignment involving ventilators, vasoactive IV medications, and unstable clients. And the question is asking you to complete each statement by choosing the best answer from the drop-down options. This question is testing whether the nurse knows how to respond to an unsafe or unfamiliar floating assignment without abandoning care. This question is testing whether the nurse knows how to respond to an unfamiliar floating assignment while still protecting client safety. Statement 1 asks what the nurse should do first when assigned to float to an unfamiliar unit. Statement 2 asks what type of assignment would be safest for the floated nurse. Statement 3 asks what the nurse should do if asked to perform care that is outside the nurse's competency. And Statement 4 asks what action the nurse should avoid. Take a moment, go through available options in each drop-down and think about your answer. The correct answers are: clarify the client assignment with the ICU team leader, stable and within the nurse's competency, notify the nursing supervisor or follow the chain of command, and avoid abandoning or refusing all care without clarification. All right, let's look at the rationale. For the first statement, the nurse's first action should be to clarify the client assignment with the ICU team leader. Floating may be necessary during staffing shortages, but the nurse must protect client safety. The nurse should not automatically refuse the assignment and should not leave the unit. The safest first step is to clarify what clients or tasks are being assigned and determine whether they are within the nurse's training and experience. For the second statement, the safest assignment for the floated nurse would include clients or tasks that are stable and within the nurse's competency. A medical surgical nurse who has not worked in the ICU should not be assigned unstable clients requiring complex ICU-level judgment, ventilator management, vasoactive medication titration, or unfamiliar equipment management. A safer assignment may include stable clients, basic nursing care, documentation support, or tasks the nurse is competent to perform. For the third statement, if the nurse is asked to perform care that cannot be provided safely, the nurse should notify the nursing supervisor or follow the chain of command. The nurse should clearly communicate what care can and cannot be safely performed. If the assignment remains unsafe after clarification, the concern should be escalated through the proper chain of command. For the fourth statement, the nurse should avoid abandoning or refusing all care without clarification. The nurse should not automatically refuse to float, abandon the assignment, or leave the unit. The safer action is to communicate concerns, clarify expectations, request support, and accept only care that can be performed safely. Now here is the NCLEX alert. Floating is not automatically unsafe. The nurse must clarify the assignment before refusing care. Do not accept tasks outside your competency. Use the chain of command for unsafe assignments. Client safety comes before staffing convenience. The key takeaway is this. Safe floating means matching the assignment to the nurse's competency. The nurse should speak up early if the assignment is unsafe. ICU clients may require skills a non-ICU nurse has not developed. Clarification comes before refusal, and the nurse remains accountable for accepting and performing safe care. Okay, let's keep building clinical judgment and move on to the next question.
Question 26, multiple choice. Expected versus unexpected findings. Clinical scenario. The nurse has completed initial rounds on 4 assigned clients. The nurse now must decide which client requires care first. And the question is asking, which client should the nurse assess first? The options are: Option 1. A client who is ambulating in the hallway with a steady gait after breakfast. Option 2. A post-operative client who received an opioid pain medication 20 minutes ago and is resting with a respiratory rate of 16 per minute. Option 3. A client scheduled for the first crutch walking session with physical therapy later this morning. Option 4. A client with a temperature of 38.4 degrees Celsius and a white blood cell count of 14,000. Take a moment and think about your answer. The correct answer is option 4. A client with a temperature of 38.4 degrees Celsius and a white blood cell count of 14,000. All right, let's look at the rationale. This client should be assessed first because fever plus an elevated white blood cell count is an unexpected finding that may indicate infection. This client needs priority assessment to identify the possible source of infection, check for worsening condition, and notify the provider if indicated. Now let's look at the other options. Option 1, the client ambulating in the hallway with a steady gait after breakfast, is not the priority. This is an expected and stable finding. The client is mobile, steady, and not showing signs of immediate risk. Option 2, the post-operative client resting after opioid pain medication with a respiratory rate of 16 per minute is also not the first priority. This client still needs reassessment after pain medication, especially for pain relief, sedation, and respiratory status. But the respiratory rate is currently stable, so this client is not the highest priority. Option 3, the client scheduled for the first crutch walking session is not the priority. This client needs teaching and safety support, but this is planned care. It does not come before a client with possible infection or physiologic instability. Now here is the NCLEX alert. Prioritize unexpected or worsening findings over stable expected findings. Fever plus elevated white blood cell count suggests possible infection. Stable scheduled care usually does not come first. Opioid reassessment is important, but stable respirations lower the urgency. In priority questions, look for the client with the greatest risk of deterioration. The key takeaway is this. Expected findings are usually lower priority. Unexpected abnormal data requires follow-up. White blood cell elevation plus fever is a red flag for infection. Priority questions often compare stable routine needs with one unstable cue. Assess first when findings suggest a new or worsening problem. Okay, let's keep building safe nursing practices while moving on to the next. Question 27. Ordered response. Managing competing client needs. Clinical scenario. The nurse is giving a bed bath to a client who is lying on the side of the bed with linens removed. An assistive personnel, or PSW, enters the room and tells the nurse that another assigned client is reporting pain and is requesting pain medication. The nurse must respond to the client in pain without leaving the client receiving the bed bath in an unsafe position. And the question is asking, place the nurse's actions in the correct order. The actions are: 1. Assess the client reporting pain and verify the medication order, allergies, and last dose time. 2. Cover the client receiving the bed bath, place the bed in a safe position, raise the side rail as appropriate, and ensure the call light is within reach. 3. Administer the prescribed pain medication if it is safe and indicated. 4. Tell the client receiving the bed bath that the nurse will return shortly. 5. Reassess the client's pain response after medication administration and return to complete or delegate appropriate hygiene care. Take a moment and think about the correct sequence. The correct order is 2, 4, 1, 3, 5. So the sequence of action is: cover the client receiving the bed bath, place the bed in a safe position, raise the side rail as appropriate, and ensure the call light is within reach. Tell the client receiving the bed bath that the nurse will return shortly. Assess the client reporting pain and verify the medication order, allergies, and last dose time. Administer the prescribed pain medication if it is safe and indicated. Then reassess the client's pain response after medication administration and return to complete or delegate appropriate hygiene care. All right, let's look at the rationale. The first action is to secure the current client's safety. The nurse should not leave a partially bathed client exposed, unsupported, or at risk for falling. Before leaving the room, the nurse should cover the client, place the bed in a safe position, raise the side rail as appropriate, and make sure the call light is within reach. The second action is to communicate before leaving. The nurse should tell the client that they will return shortly. This protects dignity, reduces anxiety, and helps prevent the client from feeling abandoned. The third action is to assess the client reporting pain and verify medication safety. Before giving pain medication, the nurse must assess the pain and check the medication order, allergies, timing of the last dose, and any safety concerns. The fourth action is to administer the prescribed pain medication if it is safe and indicated. Pain should not be ignored or delayed until the bed bath is finished. Once the nurse confirms that medication administration is appropriate, the prescribed pain medication should be given. The fifth action is to reassess and follow up. Pain medication requires reassessment to determine whether it was effective. The nurse also remains responsible for returning to the first client or making sure appropriate hygiene care is completed safely. Now, here is the NCLEX alert. Do not leave one client unsafe while responding to another. Pain is important, but the safety of the current client comes first. A P or PSW staff do not assess pain medication timing or decide whether medication is needed. Before giving PRN medication, assess the client and verify the order, allergies, and last dose. After pain medication, reassess effectiveness. The key takeaway is this: competing needs require quick, safety-first thinking. Secure the client you are currently caring for before leaving. Pain medication should not be unnecessarily delayed. Medication decisions remain the nurse's responsibility. Follow-up is required after both interrupted care and PRN medication. Great, let's move on to the next. Question 28. Drop-down close. SBAR communication for a change in client condition. Clinical scenario. The nurse is caring for a post-operative client one day after abdominal surgery. During rounds, the nurse notes that the client is newly short of breath, confused, and restless. The client's oxygen saturation is 88% on room air, heart rate is 124 per minute, and respiratory rate is 28 per minute. The nurse raises the head of the bed, applies oxygen according to facility protocol, remains with the client, and prepares to communicate the change in condition using SBAR. And the question is asking you to complete each SBAR statement by choosing the best option from the drop-down menu. This question is testing whether the nurse can organize urgent communication clearly when a client's condition is changing. Statement 1 is the situation. This asks what immediate concern the nurse should report first. Statement 2 is the background. This asks what relevant clinical context should be included. Statement 3 is the assessment. This asks how the nurse should summarize the current findings. And Statement 4 is the recommendation. This asks what the nurse needs next. Take a moment and think about your answer. The correct answers are, for situation, new shortness of breath with oxygen saturation of 88%. For background, postoperative day 1 after abdominal surgery. For assessment, signs of acute respiratory compromise and clinical deterioration. And for recommendation, immediate provider evaluation and rapid response activation if indicated. All right, let's look at the rationale. For Statement 1, the situation is the immediate concern. The nurse should report the most serious change first. The client has new shortness of breath with an oxygen saturation of 88% on room air. This is not routine postoperative discomfort. This is an urgent breathing concern. For Statement 2, the background is the relevant clinical context. The client is postoperative day 1 after abdominal surgery. That matters because postoperative clients can develop complications such as atelectasis, pneumonia, pulmonary embolism, bleeding, or other clinical deterioration. For Statement 3, the assessment is the nurse's interpretation of the findings. This client is showing signs of acute respiratory compromise and clinical deterioration. The oxygen saturation is low, the respiratory rate is elevated, the heart rate is elevated, and the client is newly confused and restless. New confusion can be a sign of hypoxia, especially when it appears with low oxygen saturation and shortness of breath. For Statement 4, the recommendation is what the nurse needs next. This client needs immediate provider evaluation and rapid response activation if indicated. The nurse should not wait until the end of the shift or treat this as routine anxiety. When a client is deteriorating, escalation should not be delayed. Now here is the NCLEX alert. SBAR helps organize urgent communication. Report the most serious change first. New confusion can be a sign of hypoxia. Oxygen saturation of 88% is not a routine finding. Do not delay escalation when a client is deteriorating. The key takeaway is this. S means what is happening now. B means relevant clinical context. A means the nurse's assessment findings. R means what the nurse needs or recommends. Clear communication prevents delayed rescue. This concludes Section 3, Management of Care, Delegation, and Prioritization. In this section, we focused on how nurses decide what matters first, what can be delegated, what must stay with the RN, who is stable versus unstable, and how to respond when multiple client needs compete at the same time. These are some of the highest yield decision-making questions in fundamentals because they test real nursing judgment.
Now we'll move into Section 4, Basic Assessment and Foundational Care. In this section, we focus on the practical assessment skills every nurse must use at the bedside. We'll cover general survey, focused assessment, head-to-toe framework, vital signs, pain, respiratory and cardiac assessment basics, mobility and balance, documentation, normal versus abnormal findings, and what must be reported. As you move through this section, think like the nurse at the bedside. What do I notice? Is this expected or abnormal? Does this require follow-up? And what finding could signal a change in the client's condition? Let's begin. Question 29. Matrix Grid. Choosing an accurate temperature route. Clinical scenario. The nurse is reviewing temperature measurement techniques with an assistive personnel, or PSW. Several clients require routine vital signs, but each client has a different condition that may affect temperature route accuracy. The nurse asks the AP, or PSW, to explain which temperature route would be appropriate for each client. And the question is asking, for each AP or PSW statement, identify whether the statement shows an appropriate method or needs further teaching. The statements include Option A, taking an oral temperature for a client who is coughing, congested, and breathing mostly through the mouth.
Option B, using an axillary temperature for a client who drank hot coffee a few minutes ago. Option C, avoiding the forehead and using the neck area behind the ear with the electronic device for a client who is diaphoretic. Option D, taking a rectal temperature for a client who had nasal surgery if no less invasive accurate route is available and no rectal contraindication exists. And option E, waiting before taking an oral temperature if the client recently smoked or drank a hot beverage. And option F, choosing an oral temperature because it is always the most accurate route for adults. Take a moment and think about your answer. The statements that show an appropriate method are option B, C, D, and option E. The statements that need further teaching are option A and option F. All right, let's look at the rationales. For option A, taking an oral temperature when the client is coughing, congested, and mouth breathing needs further teaching. An oral temperature requires the client to keep the thermometer properly placed and keep the mouth closed. Coughing, nasal congestion, and mouth breathing can affect accuracy and make the route less reliable. For option B, using an axillary temperature after the client drank hot coffee is an appropriate method. A recent hot drink can falsely affect an oral temperature. An axillary route may be used instead, although it can be less accurate than some other routes, so the nurse should follow facility policy. For option C, avoiding the forehead for a diaphoretic client is an appropriate method. Diaphoresis means sweating. Moisture on the forehead can affect some electronic temperature readings. With certain devices, using the neck area behind the ear may be appropriate according to the equipment directions. For option D, taking a rectal temperature after nasal surgery may be appropriate if no less invasive accurate route is available and no rectal contraindication exists. After nasal surgery, some routes may not be ideal, but the nurse should still consider the least invasive accurate route first and avoid rectal temperature if there are contraindications. For option E, waiting before taking an oral temperature after smoking or drinking a hot beverage is appropriate. Smoking, hot drinks, and cold drinks can alter oral temperature readings. Waiting helps improve accuracy. For option F, saying that oral temperature is always the most accurate route for adults needs further teaching. No single temperature route is always best. The correct route depends on the client's condition, ability to cooperate, recent intake, surgery, diaphoresis, equipment, and contraindications. Now here is the NCLEX alert. Avoid oral temperature with nasal congestion or mouth breathing. Recent hot or cold fluids and smoking can alter oral readings. Diaphoresis can affect forehead temperature readings. Axillary temperature may be safer in some situations, but it may be less accurate. Choose the temperature route based on the client's condition, not habit. The key takeaway is this: vital sign accuracy depends on choosing the correct route. Oral temperature requires the client to close the mouth and breathe comfortably. Use an alternate route when oral readings may be unreliable. Check contraindications before using a rectal temperature. Report abnormal vital signs and repeat questionable readings correctly. Okay, let's keep building clinical judgment and move on to the next question. Question 30, multiple choice. Abnormal respiratory pattern, Cheyne-Stokes Respirations. Clinical scenario. The nurse is completing a focused respiratory assessment on a client with a neurological condition. The previous shift documented that the client was showing Cheyne-Stokes respirations, and the question is asking, which breathing pattern should the nurse expect to observe? The options are: option 1, respirations that gradually increase and decrease in depth, followed by periods of apnea. Option 2, regular, rapid, deep respirations that are sustained without pauses. Option 3, completely irregular respirations that vary unpredictably in rhythm and depth. Option 4, irregular respirations with prolonged pauses at the end of inspiration and expiration. Take a moment and think about your answer. The correct answer is option 1, respirations that gradually increase and decrease in depth, followed by periods of apnea. All right, let's look at the rationale. Cheyne-Stokes respirations follow a repeating cycle. The breathing gradually becomes deeper and faster, then slower and more shallow, followed by a period of apnea. The major clue is the pattern of increase, decrease, and then pause. This pattern may occur with neurologic dysfunction, heart failure, or end-of-life changes. Now let's look at the other options. Option 2 is incorrect. Regular, rapid, deep respirations that are sustained without pauses describe central neurogenic hyperventilation, not Cheyne-Stokes. The key difference is that this pattern does not have the gradual waxing and waning pattern or periods of apnea. Option 3 is incorrect. Completely irregular respirations that vary unpredictably in rhythm and depth describe ataxic respirations. Cheyne-Stokes is abnormal, but it still has a recognizable cyclic pattern. Option 4 is incorrect. Irregular respirations with prolonged pauses at the end of inspiration and expiration describe apneustic respirations. The clue with apneustic breathing is the prolonged inspiratory pause, not the gradual increase and decrease seen with Cheyne-Stokes. Now, here is the NCLEX alert. Cheyne-Stokes means crescendo-decrescendo breathing plus apnea. The key word is apnea. Ataxic respirations are irregular and unpredictable. Apneustic respirations have prolonged inspiratory pauses. New abnormal respiratory patterns may signal neurologic deterioration and require follow-up. The key takeaway is this. Cheyne-Stokes has a repeating cycle. Breathing depth rises, falls, and then pauses. Apnea is the major clue. When comparing respiratory patterns, focus on rhythm, depth, and pauses. New abnormal breathing patterns should be reported and assessed further. Okay, let's keep going.
Question 31. Highlight the text. Wheezes and narrowed airways. Clinical scenario. The nurse is assessing a client admitted with an asthma exacerbation. The client reports chest tightness and shortness of breath. The nurse auscultates the lungs to identify the adventitious breath sound most commonly associated with narrowed lower airways. And the question is asking, highlight the finding that best matches the expected lung sound in this client. The respiratory assessment note says, the client has a harsh, high-pitched sound heard mainly over the neck during inspiration. Fine popping sounds are heard at the lung bases after coughing. A high-pitched musical sound is heard during expiration as air moves through narrowed airways. Breath sounds are absent over the right lower lobe. Take a moment and think about your answer. The correct finding to highlight is, a high-pitched musical sound is heard during expiration as air moves through narrowed airways. All right, let's look at the rationale. This finding describes wheezes. Asthma causes bronchoconstriction, airway inflammation, and mucus production. These changes narrow the lower airways. When air moves through narrowed airways, it can create a high-pitched musical sound called wheezing. Wheezes are often louder during expiration because the airways narrow more as the client breathes out. Now, let's look at the reasoning behind not highlighting other findings. A harsh, high-pitched sound heard mainly over the neck during inspiration describes stridor. Stridor is usually associated with upper airway obstruction. This can be an emergency finding because it may indicate narrowing above the lungs. Fine popping sounds heard at the lung bases after coughing describe crackles. Crackles are commonly associated with fluid, secretions, or the opening of collapsed alveoli. Crackles are not the classic sound of asthma-related bronchoconstriction. Absent breath sounds over the right lower lobe are also not the best answer for this question. Absent or severely diminished breath sounds can be serious, especially in asthma, because they may indicate poor air movement. But the classic adventitious breath sound associated with narrowed lower airways is wheezing. Now, here is the NCLEX alert. Asthma means narrowed lower airways, and narrowed lower airways usually produce wheezes. Wheezes are high-pitched and musical. Stridor is an upper airway emergency. Crackles suggest fluid, secretions, or alveoli opening. In severe asthma, very diminished or absent breath sounds can signal worsening obstruction. The key takeaway is this. Wheezes occur when air moves through narrowed airways. Asthma commonly produces expiratory wheezing.
Lung sound location helps identify the problem. Stridor is not the same as wheezing. Always report new severe respiratory distress or poor air movement. Okay, let's keep building clinical judgment and move on to the next. Question 32. Multiple choice. Heart murmur description. Clinical scenario. The nurse is performing a cardiac assessment on a client with a suspected incompetent heart valve. While auscultating over the precordium, the nurse hears an abnormal sound between the normal S1 and S2 heart sounds. The sound is caused by turbulent blood flow across the valve. And the question is asking, which description should the nurse use when documenting this finding? The options are: Option 1, normal lub-dub heart sounds. Option 2, a scratchy, leathery sound heard with cardiac movement. Option 3, a blowing or swooshing sound. Option 4, an abrupt, high-pitched snapping sound. Take a moment and think about your answer. The correct answer is option 3, a blowing or swooshing sound. All right, let's look at the rationale. A heart murmur is an abnormal heart sound caused by turbulent blood flow through or around a valve. Because this client has a suspected incompetent heart valve, the nurse should connect turbulent blood flow with a murmur. Murmurs are commonly described as blowing, whooshing, or swooshing sounds. Now let's look at the other options. Option 1 is incorrect. Normal lub-dub describes S1 and S2 heart sounds. These are expected sounds from valve closure, not a murmur. Option 2 is incorrect. A scratchy, leathery sound heard with cardiac movement describes a pericardial friction rub. This may occur when inflamed pericardial layers rub together, but it is not the typical sound of turbulent blood flow through a valve. Option 4 is incorrect. An abrupt, high-pitched snapping sound describes a click. A click may be associated with valve abnormalities, such as mitral valve prolapse, but it is not the classic description of a murmur. Now, here is the NCLEX alert. NCLEX may describe the sound instead of naming the condition. For a murmur, look for blowing, whooshing, or swooshing, and connect it with turbulent blood flow. Do not choose lub-dub because that describes normal S1 and S2. The key takeaway is this: cardiac sounds are identified by quality, timing, and location. Incompetent valves can cause turbulent flow. Murmurs are abnormal and should be documented clearly. Compare abnormal sounds with normal S1 and S2, and remember that new or symptomatic murmurs require follow-up. Okay, let's move on to the next one. Question 33. NGN type bow tie. Romberg test and balance/fall risk. Clinical scenario. The nurse is performing a focused neurological and mobility assessment on an older adult client who reports feeling unsteady when walking to the bathroom at night. The nurse asks the client to stand with the feet together and arms at the sides, then close the eyes while the nurse remains close for safety. The client begins to sway significantly, and the nurse supports the client to prevent a fall. And the question is asking you to complete the bow tie by selecting 3 things. First, one finding that supports a positive Romberg test. Second, 2 priority nursing actions. And third, 2 findings the nurse should monitor or report. For the finding that supports a positive Romberg test, the options are: Option A, involuntary rhythmic twitching of the eyeballs. Option B, dorsiflexion of the great toe with fanning of the other toes. Option C, significant sway or loss of balance when standing with feet together and eyes closed. Option D, inability to return an extended finger to a specific point of reference. For the priority nursing actions, the options are: Option E, stay close to the client, guard during the test, and assist the client if balance is lost. Option F, leave the client standing alone to observe the natural balance pattern. Option G, initiate fall precautions and assist with ambulation as needed. Option H, encourage the client to walk independently to build confidence. For findings to monitor or report, the options are: Option I, new dizziness, unsteady gait, or recent falls. Option J, the client's preferred footwear color. Option K, new weakness, change in level of consciousness, or worsening neurological status. Option L, the client's ability to repeat the test instructions. Take a moment and think about your answer. For the finding that supports a positive Romberg test, the correct answer is option C, significant sway or loss of balance when standing with feet together and eyes closed. All right, let's look at the rationale. A positive Romberg test occurs when the client loses balance or sways significantly after closing the eyes. This may suggest problems with balance, proprioception, vestibular function, or neurological control. Option A describes nystagmus, which is abnormal eye movement. Option B describes a positive Babinski sign, which may indicate central nervous system disease in clients older than 2 years. Option D describes impaired coordination, such as difficulty with finger-to-nose testing. The Romberg clue is balance loss after the eyes are closed. For the priority nursing actions, the correct answers are option E and option G. Option E is correct because the nurse must stay close, guard the client, and assist if balance is lost. This test can create an immediate fall risk, so the nurse should never leave the client unsupported. Option G is also correct because a positive Romberg test increases concern for fall risk. The nurse should initiate fall precautions and assist with ambulation as needed. Option F is unsafe because leaving the client standing alone can lead to a fall. Option H is also unsafe because independent ambulation may not be appropriate until the client's balance and fall risk have been addressed. For the findings to monitor or report, the correct answers are option I and option K. Option I is correct because new dizziness, unsteady gait, or recent falls increase concern for fall risk and require follow-up. Option K is correct because new weakness, change in level of consciousness, or worsening neurological status may indicate a worsening condition and should be reported promptly. Option J is incorrect because footwear safety matters, but the color of the footwear is not clinically relevant. Option L is not the priority finding to monitor or report. Understanding instructions is helpful, but it is less urgent than dizziness, gait instability, weakness, or mental status changes. Now here is the NCLEX alert. NCLEX may mix up Romberg with other neurological tests. Do not choose Babinski, nystagmus, or finger-to-nose coordination findings. The Romberg clue is loss of balance after the eyes are closed. And during the test, the nurse must protect the client from falling. The key takeaway is this. Romberg testing evaluates balance and postural stability. A positive result means significant sway or loss of balance with the eyes closed. The nurse should guard the client during the test. A positive Romberg finding increases fall risk concern. New gait changes, dizziness, weakness, or mental status changes require follow-up. Okay, let's keep building clinical judgment and move on to the next. Question 34. Select all that apply. Focused respiratory assessment. Clinical scenario. A client comes to the clinic reporting a cough, nasal congestion, fatigue, and chest congestion for 3 days. The client says, "I feel like I have a cold, but my cough is getting worse." The nurse prepares to perform a focused assessment based on the client's current symptoms. And the question is asking, which assessment actions should the nurse include? Remember, this is SATA, so more than one option may be correct. The options are: Option A, auscultate the client's lung sounds. Option B, obtain the client's temperature. Option C, assess the strength of the client's peripheral pulses. Option D, assess the client's respiratory rate, rhythm, and effort. Option E, perform a complete musculoskeletal and neurological examination. Option F, ask about the client's full family history of chronic diseases. Option G, assess oxygen saturation. Option H, ask about cough characteristics and sputum production. Take a moment and think about your answer. The correct answers are option A, option B, option D, option G, and option H. All right, let's look at the rationale. The key word in this question is focused. A focused assessment means the nurse targets the client's current problem. This client is reporting cough, nasal congestion, fatigue, and chest congestion, so the assessment should focus on respiratory status, oxygenation, and possible infection. Option A is correct. The nurse should auscultate lung sounds because the client reports cough and chest congestion. The nurse is listening for abnormal sounds such as wheezes, crackles, diminished breath sounds, or rhonchi. Option B is correct. The nurse should obtain the client's temperature. Fever with respiratory symptoms may suggest infection and may require follow-up. Option C is incorrect. Peripheral pulse strength is part of a vascular or cardiovascular assessment. It is not the priority for a focused assessment of cough and chest congestion unless the client has signs of poor perfusion. Option D is correct. The nurse should assess respiratory rate, rhythm, and effort. This helps determine how well the client is breathing. Tachypnea, accessory muscle use, or increased work of breathing would be concerning. Option E is incorrect. A complete musculoskeletal and neurological examination may be part of a full assessment, but it is not the focus for this client's current respiratory complaint. Option F is incorrect. A full family history of chronic diseases may be part of a complete health history, but it is not the priority in an acute focused respiratory assessment. Option G is correct. Oxygen saturation gives important information about oxygenation. A low oxygen saturation would require prompt follow-up. Option H is correct. The nurse should ask about cough characteristics and sputum production. The nurse should find out whether the cough is dry or productive, how long it has lasted, and whether sputum is present. Sputum color, amount, odor, or blood can help identify infection or worsening respiratory status. Now, here is the NCLEX alert. NCLEX may use the word focused to see if you can avoid choosing a full head-to-toe assessment. Match the assessment to the client's complaint. For cough and congestion, think lung sounds, respirations, oxygenation, temperature, and sputum, not unrelated body systems. The key takeaway is this: a focused assessment targets the client's current problem. Respiratory complaints require lung sounds and breathing assessment. Temperature helps screen for infection. Oxygen saturation helps evaluate oxygenation. Broad family history and unrelated systems belong more with a complete assessment, not a focused respiratory assessment. Okay, let's see the final question of this section. Question 35. Select all that apply. Objective documentation. Clinical scenario. The nurse is reviewing charting notes written during a shift. The nurse wants to ensure that documentation is factual, specific, and based on what was observed, measured, heard, or directly stated by the client. And the question is asking, which notes reflect accurate nursing documentation? Remember, this is SATA, so more than one option may be correct. The options are: Option A. Client observed sleeping during hourly rounds from 2300 to 0500. Option B. Abdominal wound dressing is dry and intact, no drainage noted. Option C. Client seemed angry when awakened for vital signs. Option D. Client appears anxious before respiratory treatments. Option E. Left lower medial leg wound measures 3 centimeters in length. No redness, drainage, or edema noted. Option F. Client refused to ambulate because the client is lazy. Option G. Client stated, "I feel nervous before my breathing treatment." Option H. Client had a bad night. Take a moment and think about your answer. The correct answers are Option A, Option B, Option E, and Option G. All right, let's look at the rationale. The key idea here is that nursing documentation should be specific, neutral, factual, and based on what the nurse saw, heard, measured, did, or what the client directly stated. Option A is correct. Client observed sleeping during hourly rounds from 2300 to 0500 is objective and specific. It documents what the nurse observed and includes a clear time frame. Option B is correct. Abdominal wound dressing is dry and intact, no drainage noted, is factual wound documentation. It describes the dressing condition and the absence of drainage without adding opinion. Option C is incorrect. Client seemed angry is an interpretation. The nurse should document observable behaviors instead, such as the client raised their voice, refused the blood pressure cuff, or stated, "Do not wake me again." Option D is incorrect. Client appears anxious is vague and opinion-based. Better documentation would include objective behaviors or the client's exact words. Option E is correct. Left lower medial leg wound measures 3 centimeters in length. No redness, drainage, or edema noted is accurate documentation because it includes location, measurement, and objective assessment findings. Option F is incorrect. Client refused to ambulate because the client is lazy is judgmental and inappropriate. The nurse should document the client's actual statement or behavior, not a personal opinion about motivation. Option G is correct. Client stated, "I feel nervous before my breathing treatment," is accurate documentation. Direct client quotes are acceptable because they record subjective data using the client's own words. Option H is incorrect. Client had a bad night is vague and not measurable. The nurse should document specific findings, such as sleep pattern, pain reports, vital signs, call bell use, or observed restlessness. Now, here is the NCLEX alert. NCLEX often hides the wrong answer in words like seems, appears, lazy, good, bad, or normal. Choose documentation that is measurable, observable, specific, or written as the client's exact quote. The key takeaway is this. Objective documentation records what the nurse sees, hears, measures, or does. Avoid vague terms and personal opinions. Use exact client quotes for subjective statements. Wound documentation should include size, location, drainage, redness, and edema. Accurate charting is specific, neutral, and factual. This concludes Section 4, Basic Assessment and Foundational Care. Now, let's move into Section 5, Nutrition, Hydration, and Elimination Basics. In this section, we focus on the everyday body systems that give nurses important clues about a client's condition: nutrition, hydration, fluid balance, intake and output, diet tolerance, electrolytes, swallowing safety, and bowel and bladder patterns. As you move through this section, keep asking, is this expected? Is the client hydrated? Is the diet safe? Is there an aspiration risk? And does this bowel or bladder change require follow-up? Question 36. Drop-down close. Dehydration and BUN improvement. Clinical scenario. A client is admitted with gastroenteritis, vomiting, diarrhea, and dehydration. The client has dry mucous membranes, poor skin turgor, and concentrated urine. The provider prescribes IV fluids. The nurse reviews the client's follow-up laboratory results to determine whether volume replacement has been effective. And the question is asking you to complete each statement by choosing the best option from the drop-down menu. This question is testing whether the nurse can connect a laboratory value with the client's hydration status. The laboratory value that best supports improved hydration is a BUN of blank, 3 milligrams per deciliter, / 15 milligrams per deciliter, / 29 milligrams per deciliter, / 35 milligrams per deciliter. A BUN of 29 milligrams per deciliter or 35 milligrams per deciliter would most likely suggest blank, continued dehydration / adequate volume replacement / fluid volume overload. A BUN of 3 milligrams per deciliter is blank, below the expected range / within the expected range / above the expected range, and may be seen with excess fluid volume or other conditions. The nurse should interpret a normalizing BUN together with blank, improved urine output and moist mucous membranes, / increased vomiting and concentrated urine, / worsening dizziness and tachycardia. Take a moment to consider all options and think about your answer. The correct answers are, for statement 1, 15 milligrams per deciliter. For statement 2, continued dehydration. For statement 3, below the expected range. And for statement 4, improved urine output and moist mucous membranes. All right, let's look at the rationale. For statement 1, the laboratory value that best supports improved hydration is a BUN of 15 milligrams per deciliter. The expected BUN range is about 10 to 20 milligrams per deciliter. So a value of 15 is within the expected range and suggests the client's volume status is improving. For statement 2, a BUN of 29 or 35 most likely suggests continued dehydration. BUN can rise when a client is dehydrated because decreased circulating volume can reduce kidney perfusion and concentrate waste products in the blood. So if the BUN is still elevated, the client may still be volume depleted. For statement 3, a BUN of 3 is below the expected range. This is not the goal when treating dehydration. A very low BUN may be seen with excess fluid volume or other conditions, but in this scenario, the nurse is looking for return to the normal range. For statement 4, the nurse should interpret a normalizing BUN together with improved urine output and moist mucous membranes. A lab value should not be interpreted alone. Improved hydration is supported by better urine output, moist mucous membranes, improved skin turgor, stable vital signs, and decreased dizziness. Now here is the NCLEX alert. NCLEX may give several lab values and ask which one shows improvement. Do not just pick the lowest number. For dehydration, the best sign of adequate replacement is the value returning to the normal range, not dropping below normal. The key takeaway is this. Normal BUN is about 10 to 20 milligrams per deciliter. Elevated BUN can occur with dehydration. A normalizing BUN supports improved hydration. Very low BUN is not the goal in dehydration treatment. Always connect lab trends with assessment findings. Okay, let's keep building clinical judgment and move on to the next question. Question 37. Select all that apply. Hypernatremia and low-sodium food choices. Clinical scenario. The nurse reviews laboratory results for a client and notes a serum sodium level of 150 milliequivalents per liter. The nurse recognizes this as hypernatremia and reinforces dietary teaching for choosing foods lower in sodium. And the question is asking, which foods are acceptable choices for the client? Remember, this is SATA, so more than one option may be correct. The options are Option A, fresh peas. Option B, unsalted nuts. Option C, cheese. Option D, fresh cauliflower. Option E, processed oat cereal. Option F, canned soup. Option G, fresh apple slices. Take a moment and think about your answer. The correct answers are Option A, Option B, Option D, and Option G. All right, let's look at the rationale. The key idea here is that a sodium level of 150 is above the normal range. Normal sodium is about 135 to 145 milliequivalents per liter. So this client has hypernatremia, and the nurse should reinforce lower sodium food choices. Option A is correct. Fresh peas are generally lower in sodium unless salt, sauces, or canned processing are added. Fresh vegetables are usually better choices for a client who needs to reduce sodium. Option B is correct. Unsalted nuts can be included as a lower sodium option. The key word is unsalted. Salted nuts would not be the best choice. Option C is incorrect. Cheese is commonly high in sodium, so it should be limited or avoided when the client needs lower sodium food choices. Option D is correct. Fresh cauliflower is a lower sodium vegetable and is an appropriate choice for this client. Option E is incorrect. Processed oat cereal can contain added sodium. The word processed is an NCLEX clue that the food may be higher in sodium. Option F is incorrect. Canned soup is often high in sodium unless it is specifically labeled low sodium. In this question, canned soup is not the best choice. Option G is correct. Fresh apple slices are usually naturally low in sodium and are appropriate unless the client has another dietary restriction. Now here is the NCLEX alert. NCLEX may first test whether you recognize 150 milliequivalents per liter as hypernatremia, then hide the answer in food wording. Choose fresh or unsalted foods, and be cautious with processed, canned, salted, or cheese-based foods. The key takeaway is this. Normal sodium is about 135 to 145 milliequivalents per liter. A sodium level of 150 indicates hypernatremia. Fresh fruits and vegetables are usually lower in sodium. Unsalted matters when choosing nuts. Processed, canned, and cheese foods are common high-sodium traps. Okay, let's move on. Question 38. Matrix grid. Clear liquid versus full liquid diet. Clinical scenario. A postoperative client is progressing from a clear liquid diet to a full liquid diet. The nurse is reviewing which foods are appropriate at each stage of diet advancement. And the question is asking, for each food item, identify whether it is allowed on a clear liquid diet, allowed on a full liquid diet, or not appropriate for either a clear or full liquid diet. For this question, select the most restrictive diet level on which each item would first be allowed. The food items are Option A, clear broth. Option B, coffee without milk or cream. Option C, gelatin. Option D, custard. Option E, pudding. Option F, strained cream soup. Option G, pureed vegetables. Option H, ice pop. Take a moment and think about your answer. The correct classifications are: clear broth is allowed on a clear liquid diet. Coffee without milk or cream is allowed on a clear liquid diet. Gelatin is allowed on a clear liquid diet. Custard is allowed on a full liquid diet. Pudding is allowed on a full liquid diet. Strained cream soup is allowed on a full liquid diet. Pureed vegetables are not appropriate for a clear or full liquid diet. And an ice pop is allowed on a clear liquid diet. All right, let's look at the rationales. Option A, clear broth, is a clear liquid. Clear broth is transparent and liquid at room temperature or body temperature, so it is allowed on a clear liquid diet. Option B, coffee without milk or cream, is also a clear liquid. Plain coffee is considered a clear liquid because it does not contain milk, cream, or solid particles. Option C, gelatin, is a clear liquid. Even though gelatin may look like a soft solid, it melts into liquid at body temperature and is considered acceptable on a clear liquid diet. Option D, custard, is a full liquid. Custard is not clear, but it is smooth and semi-liquid. That makes it appropriate for a full liquid diet, not a clear liquid diet. Option E, pudding, is also a full liquid. Pudding is smooth and does not require chewing, but it is not transparent enough for a clear liquid diet. Option F, strained cream soup, is a full liquid. Because it is smooth and liquid, it is allowed on a full liquid diet. But because it is not transparent, it is not allowed on a clear liquid diet. Option G, pureed vegetables, are not appropriate for a clear or full liquid diet. Pureed vegetables are thicker and are usually part of a pureed or soft diet, not a clear liquid or full liquid diet. Option H, an ice pop, is a clear liquid. Ice pops are allowed on a clear liquid diet because they melt into a clear liquid at room or body temperature. Now, here is the NCLEX alert. NCLEX may try to trick you with foods that look solid but melt into clear liquid, such as gelatin and ice pops. These count as clear liquids. Foods like custard, pudding, milk, and strained cream soups belong to the full liquid diet because they are smooth or liquid, but not clear. The key takeaway is this: clear liquids are transparent and liquid at room or body temperature. Clear broth, plain coffee or tea, gelatin, and ice pops are clear liquids. Full liquids include smooth, non-clear liquids such as custard, pudding, milk, and strained cream soups. A full liquid diet is more advanced than a clear liquid diet, and pureed foods are not the same as full liquids. Okay, let's keep building clinical judgment and move on to the next question.
Question 39, multiple choice. Vegan diet and vitamin B12 risk. Clinical scenario. The nurse is completing a dietary assessment for a client who follows a strict vegan diet. The client does not eat meat, fish, eggs, dairy products, or other animal-based foods. The client reports fatigue and occasional numbness and tingling in the feet. The nurse reviews the client's diet and plans teaching about the nutrient most likely to be lacking in a strict vegan diet unless fortified foods or supplements are used. And the question is asking, which teaching point should the nurse include? The options are: Option 1. Increase citrus fruits and strawberries because vitamin C is commonly lacking in vegan diets. Option 2. Include fortified plant milks, fortified cereals, nutritional yeast, or a supplement to help meet vitamin B12 needs. Option 3. Increase carrots, sweet potatoes, and leafy greens because vitamin A is absent from vegan diets. Option 4. Increase nuts and vegetable oils because vitamin E is usually unavailable in plant-based diets. Take a moment and think about your answer. The correct answer is Option 2. Include fortified plant milks, fortified cereals, nutritional yeast, or a supplement to help meet vitamin B12 needs. All right, let's look at the rationale. Vitamin B12 is primarily found in animal-based foods. Because this client follows a strict vegan diet and does not eat meat, fish, eggs, dairy products, or other animal-based foods, the client is at risk for vitamin B12 deficiency unless fortified foods or supplements are used. The symptoms in the scenario also matter. Fatigue, numbness, and tingling can be associated with low vitamin B12. Vitamin B12 deficiency may contribute to anemia and neurologic changes. Option 1 is incorrect. Vitamin C is commonly found in fruits and vegetables, such as citrus fruits and strawberries. A vegan diet does not automatically place the client at high risk for vitamin C deficiency. Option 3 is incorrect. Vitamin A is not absent from vegan diets. Plant foods such as carrots, sweet potatoes, and leafy greens provide carotenoids, which the body can convert to vitamin A. Option 4 is incorrect. Vitamin E is found in plant-based foods such as nuts, seeds, and vegetable oils. It is not the main vitamin concern in a strict vegan diet. Now, here is the NCLEX alert. NCLEX may pair a vegan diet with fatigue, anemia, numbness, tingling, or neurologic symptoms. Do not choose vitamins commonly found in fruits and vegetables. The classic vegan diet trap is vitamin B12 because reliable sources are usually animal foods, fortified foods, or supplements. The key takeaway is this: strict vegan diets increase the risk for vitamin B12 deficiency. Vitamin B12 deficiency may cause anemia and neurologic symptoms. Fortified foods or supplements may be needed for adequate B12 intake. Vegan diets may also require attention to iron, calcium, vitamin D, and omega-3 intake. Fruits and vegetables usually provide vitamins such as vitamin C and vitamin A. Great work building nutrition-related insight. Let's go to the next one. Question 40. Select all that apply. High potassium food choices. Clinical scenario. The nurse is reinforcing diet teaching for a client with a low serum potassium level. The client asks, which food should I choose to help increase my potassium? And the question is asking, which foods should the nurse include in the teaching? Remember, this is SATA, so more than one option may be correct. The options are Option A, peas. Option B, raisins. Option C, potatoes.
Option D, cantaloupe. Option E, cauliflower. Option F, strawberries. Take a moment and think about your answer. The correct answers are Option B, raisins. Option C, potatoes. Option D, cantaloupe. And Option F, strawberries. All right, let's look at the rationale. The key idea here is that the client has a low potassium level, so the nurse should reinforce potassium-containing food choices. Normal potassium is about 3.5 to 5.0 milliequivalents per liter. When potassium is low, the client may need teaching about foods that can help increase potassium intake, unless there is a kidney problem or another restriction. Option A is incorrect. Peas are nutritious, but in this question, they are not one of the best potassium choices from the list. Peas are more commonly associated with magnesium content in basic nutrition-style questions. Option B is correct. Raisins are a high potassium food and can be included when teaching a client to increase dietary potassium. Option C is correct. Potatoes are a common high potassium food. This is a strong answer choice when the question asks about foods that help raise potassium intake. Option D is correct. Cantaloupe is a fruit source of potassium and is appropriate for a client who needs more potassium in the diet. Option E is incorrect. Cauliflower is healthy, but it is not one of the best potassium answers in this list. In basic nutrition questions, cauliflower may be more commonly linked with magnesium content. Option F is correct. Strawberries contain potassium and are included as an acceptable potassium-containing food choice. Now here is the NCLEX alert. NCLEX may give a simple nutrition question after showing a low potassium level. Do not overthink it into advanced electrolyte management. Pick common potassium foods such as potatoes, raisins, cantaloupe, strawberries, bananas, oranges, tomatoes, and spinach. The key takeaway is this. Normal potassium is about 3.5 to 5.0 milliequivalents per liter. Low potassium may require potassium-rich food teaching. Potatoes, raisins, cantaloupe, and strawberries are potassium-containing foods. Peas and cauliflower are not the best potassium answers in this item. Always follow diet restrictions if the client has kidney disease or another potassium limitation. Okay, let's keep building clinical judgment and move on to the next. Question 41. Numeric entry, intake and output calculation. Clinical scenario. The nurse is calculating a client's intake and output for the shift. The client consumed 6 ounces of water and 8 ounces of juice. The client also had emesis, 120 milliliters. Wet diaper number 1, 50 grams. Wet diaper number 2, 52 grams. Wet diaper number 3, 46 grams. And the dry diaper weight is 30 grams. The nurse is asked to document the client's total oral intake for the shift. And the question is asking, how many milliliters of oral intake should the nurse document? Record your answer using a whole number. Take a moment and calculate your answer. The correct answer is 420 milliliters. All right, let's look at the calculation. The standard conversion is 1 ounce equals 30 milliliters. First, convert the water. 6 ounces times 30 milliliters equals 180 milliliters. Next, convert the juice. 8 ounces times 30 milliliters equals 240 milliliters. Now add the oral intake together. 180 milliliters plus 240 milliliters equals 420 milliliters. So the nurse should document 420 milliliters as the client's oral intake. Now let's look at why the other information is not included. The emesis is not intake. Emesis is fluid lost from the body, so it is documented as output. The wet diaper weights are also not intake. Wet diapers are used to estimate urine output. The dry diaper weight is used only when calculating output from the wet diaper weights. It is not part of oral intake. The key trap in this question is that both intake and output data are given, but the question only asks for oral intake. Now, here is the NCLEX alert.
NCLEX may include both intake and output data in the same question to distract you. Before calculating, identify exactly what the question is asking for. If it asks for intake, count only fluids taken into the body. Do not add emesis, urine, drains, or wet diapers. The key takeaway is this: 1 ounce equals 30 milliliters. Oral fluids count as intake. Emesis counts as output. Wet diapers are used to estimate urine output. Always answer the exact calculation being asked. Okay, let's keep going. We are approaching final question of Section 5, Nutrition, Hydration, and Elimination Basics. Here we go. Question 42. Ordered response. Bowel and bladder assessment. Expected versus reportable findings. Clinical scenario. The nurse is caring for several clients on a long-term care unit during the morning assessment. The assistive personnel, or PSW, reports several bowel and bladder findings from the shift. The nurse must determine which findings require follow-up and prioritize care. And the question is asking, place the findings that require nursing follow-up in order of priority, from highest priority to lowest priority. Use only the findings that require follow-up. The findings are: Option A. A client has not had a bowel movement for 2 days, but denies abdominal pain, nausea, or bloating. Option B. A client reports burning with urination and has new urinary frequency. Option C. A client has had 3 episodes of watery diarrhea during the shift. Option D. A client has voided 80 milliliters of dark amber urine over the past 6 hours. Option E. A client reports a usual bowel pattern of 1 bowel movement every other day. Option F. A client has lower abdominal distension and states, "I feel like I need to urinate, but I can't." Option G. A client who is usually continent has 2 new episodes of urinary incontinence today. Option H. A client reports mild straining with a firm bowel movement after eating less fiber than usual. Take a moment and think about which findings require follow-up and which one is the highest priority. The correct priority order is F, D, C, B, G. So the nurse should follow up first on the client with lower abdominal distension and inability to urinate. Second, the client who voided only 80 milliliters of dark amber urine over 6 hours. Third, the client with 3 episodes of watery diarrhea during the shift. Fourth, the client with burning during urination and new urinary frequency. And fifth, the client with new urinary incontinence who is usually continent. All right, let's look at the rationale. Option F is the highest priority. Lower abdominal distension with the feeling of needing to urinate but being unable to void suggests urinary retention. This requires prompt follow-up because bladder distension can cause pain, bladder overdistension, infection risk, and possible bladder injury. The nurse should assess the bladder, review the time and amount of the last void, and follow facility protocol such as bladder scanning or provider notification. Option D is the second priority. Voiding only 80 milliliters of dark amber urine over 6 hours is a very low urine output for that time period. This may indicate dehydration, inadequate fluid intake, or poor fluid balance. The dark amber urine also suggests concentrated urine. The nurse should assess intake, vital signs, mucous membranes, skin turgor, and overall hydration status. Option C is the third priority. 3 episodes of watery diarrhea during the shift require follow-up because repeated diarrhea can quickly lead to dehydration, electrolyte imbalance, weakness, skin breakdown, and increased fall risk. The nurse should assess fluid status, abdominal symptoms, skin condition, and possible infection control concerns.
Option B is the fourth priority. Burning with urination and new urinary frequency may indicate a urinary tract infection. The nurse should assess urine characteristics, temperature, suprapubic discomfort, hydration status, and report findings according to facility policy. Option G is the fifth priority. New urinary incontinence in a client who is usually continent is not automatically normal. It may be related to infection, delirium, mobility changes, medications, toileting barriers, or functional decline. It also increases the risk for skin breakdown and falls. Now let's look at the findings that are not included in the priority sequence. Option A is not the priority. No bowel movement for 2 days without abdominal pain, nausea, or bloating may simply need monitoring. The nurse should compare this with the client's usual bowel pattern and assess hydration, mobility, fiber intake, and discomfort. Option E is an expected finding. A usual bowel pattern of 1 bowel movement every other day can be normal for that client. Bowel patterns vary, so if this is the client's baseline and there are no concerning symptoms, it does not require priority follow-up. Option H is a lower concern. Mild straining with a firm bowel movement after eating less fiber suggests mild constipation. The nurse can encourage fluids if not contraindicated, mobility and fiber intake, but this is lower priority than urinary retention, very low urine output, repeated diarrhea, or urinary tract infection symptoms. Now, here is the NCLEX alert. NCLEX may try to make every bowel or bladder change look urgent. First ask, is this the client's normal baseline pattern, or is this a new or reportable change? The biggest traps are missing urinary retention, very low urine output, and new incontinence because they may look less dramatic than diarrhea, but they still require nursing follow-up. The key takeaway is this. Urinary retention with bladder distension is the highest priority. Very low urine output may signal dehydration or fluid imbalance. Repeated diarrhea can cause dehydration, skin breakdown, weakness, and falls. Dysuria and frequency may indicate a urinary tract infection. New incontinence requires assessment and is not automatically normal aging. And bowel patterns should always be compared with the client's usual baseline. All right, that brings us to the end of this full review of Fundamentals of Nursing chapter at NCLEX-ReviewPro. Our motto, prep like a pro, let the worries go. Let's quickly zoom out and connect everything we've covered. The core foundation of safe nursing care, clinical judgment, the nursing process, safety, infection control, delegation, prioritization, assessment, documentation, nutrition, hydration, and elimination. Remember, fundamentals is not just about memorizing facts. It is about learning how to think like a nurse, noticing the right cues, identifying what is unsafe, deciding what comes first, and choosing the action that protects the client. As you continue preparing for the NCLEX, keep practicing these patterns. Assess before acting, prioritize the unstable client, recognize new or unexpected findings, delegate safely, and always choose the answer that supports client safety. Great work completing this chapter. Subscribe and visit NCLEXReviewPro.com. Sign up there because we've got more Q&A sessions, mock exams, visual study guides, and audio overviews, and plenty of high-yield quizzes. See you in next session.